Everybody's ready?
Yes.
Okay. Good morning, everyone. I'm going to call this meeting to order. Welcome. I want to welcome the medical students at Midwestern University, Arizona College of Osteopathic Medicine, A.T. Still College of Osteopathic Medicine, and also A.T. Still School of Osteopathic Medicine in Arizona. Do I have all those people? Who's from A.T. Still? Anybody from Midwestern? Anybody else I've missed? Welcome. I hope this will be a learning experience for you. Please put your cell phones away. I want you to please listen very closely. And we're going to have you come up and ask you some questions afterwards. But we're glad you're here, okay? Next, if any member of the public...
Dr. Cunningham, we need to do a roll call. I'm
sorry. I told you I had a late flight last night. Okay. I got in at 10, so I need some more coffee. Can I have a roll call, please?
Yes. Dr. Reese. Dr. Madam?
Here.
Dr. Erbstrasser?
Here.
Mr. Landau?
Present.
Dr. Cunningham?
Here.
Dr. Speakerman and Mr. Berg are absent.
We have a quorum. Thank you for keeping me in line. All right, now I'm going to do the call to the public. If any member of the public who is not a respondent, licensee, or applicant, or a complainant wishes to address the board on a matter that appears on the agenda, you will be asked to speak during the call to the public. If you want to address the board on the issue that's not on the agenda, you will be asked to speak during the call to the public. And all those wishing to speak should fill out a speaker form and give it to a staff member. The mission of the board is to protect the public by setting educational and training standards for licensure and by reviewing complaints made against osteopathic physicians, interns, and residents to ensure their conduct meets the standards of the profession as defined by law. All right. Are we ready to move on? Okay, so we're going to go to review and consideration and approval of the minutes. I have August 10, 2019, open session. Has everyone had a chance to review those? All right. If so, can I have a motion?
I would like to make a motion to approve.
I have a motion from Dr. Madam. Do I have a second?
Second.
Second from Dr. Erbstrasser. All in favor signify by saying aye.
Aye.
All opposed, same sign.
Dr. Reese is abstaining.
And Dr. Reese will be abstaining. All right. We'll note that in the record, please. Next is B, August 10, 2019, executive session. Have everyone had a chance to review those?
Motion to approve.
Motion to approve by Dr. Madam. Can I have a second?
Second.
Second by Dr. Erbstrasser. All in favor signify by saying aye.
Aye.
All opposed, same sign. And we have
Abstain.
Abstain from Dr. Reese. Next and last is March 23, 2019, special meeting draft minutes. Has everyone had a chance to review those minutes?
Yes. Motion to approve.
Motion to approve by Dr. Madam. Can I have a second? Second?
I have to abstain.
Second motion. Second from Mr. Landau. All in favor signify by saying aye.
Aye.
All opposed, same sign. And we will note that Dr. Erbstrasser had to abstain. All right. We're ready to move on to 5. This is a review and discussion and action on case reviews of allegations of unprofessional contact. This is AZDO-19-00258, Dr. Michael Napsey's Local, DO, license number 005981. Is the doctor here? Please come forward and have a seat right there, sir. I want to remind everyone this is just a review. This is not an investigative. Please have a seat right there. Welcome, doctor. This is not an investigative hearing. This is strictly to gain more information to see if we will move forward or not. Did you say we were going to have the...
The complainant is present as well.
Is the complainant is present as well? All right. All right. I know that there were questions. Were there any questions from board members? Because all the 3 that I think reviewed said case review. What questions do you have?
Well, I'd like to hear in his words just what happened.
Okay. Do you want to move it to investigative hearing, or do you want to go through the whole thing, or do you just need a few things?
I just want to, in his opinion, what really happened with ordering the Ferritons and keep it short.
Yes, sir. Thank you for having me. I think when I saw the patient the first time, I was looking at how to order the like a standard order, a standing order. And I was so involved in that I forgot to order the rest of the labs, and because they're all in standing orders, I couldn't really catch that. But once the patient informed us that there's only a CBC in here, we try to correct the error.
Now, what was the problem with the phones?
We changed to a new phone system, and there were problems with voicemails and my medical assistants getting the messages, and there was a lot of crossover, and they didn't really have a good phone system, and they didn't have enough people manning the phones. So what happened was would get messages to my medical assistants. They would never get the information, and there was a lot of back and forth with the phone system. So in the end, she decided to just send messages through the portal system, and that's when we realized, wait a minute, I think there's a problem here. I didn't order, the initial labs didn't include the first all the labs that needed to be in for the hemochromatosis. So, but once I noticed that, we ordered the labs. Now, there was also a problem because for about a week and a half I was out of town. I was in New Orleans for the FMX conference, and I wasn't able to get all the information in time. So.
And what type of practice is this?
Family medicine.
Family medicine?
Yes, sir.
Are you in private practice, or are you working for a group?
I'm in a group, so a lot of the decisions that are made are kind of out of my realm. I make recommendations, but I don't get to say what phone system we use or who the vendor is, and we've had a lot of issues. But now I think the administration is taking note, and they're trying to improve it.
Any questions from anybody else before we have the complainant come forward? Go ahead.
No questions, but a comment.
Yes, sir.
I think there are questions I would like to ask, especially regarding the conversations between doctor and patient's wife, but they're more, I think, adept to or more appropriate for an investigative hearing than a case review. So I'll refrain from asking the questions now, but I would like, since the patient is here or the complainant is here, I'd like to hear from them.
Is the complainant here? Go ahead and have a seat right there. Welcome, ma'am. Have a seat right there. This is just a case review, so we're not going into a complete investigative hearing. If you have anything to add, we'd like to hear that to sway our opinion one way or the other, okay?
Okay.
All right, welcome, though.
Thank you. And could we have a reminder to use initials, please?
Just use your initials. Please don't use your name to protect your identity and so forth, okay?
First, I wanted to explain that I'm here basically because...
Could you talk into the microphone? I'm sorry. Some of us are getting harder of hearing, okay?
First, I wanted to explain that I'm here because my husband had a brain injury, and so when we met with Dr. Locale for the first time, I go to all of his appointments and oversee his medical care. The first appointment that we went, I explained to him that my husband had genetic hemochromatosis for the last 20 years, that he needs his iron tested, the bloods need to be drawn regularly, and this is what we were here for him to monitor. On March 5th, he did a blood draw. On March 18th, the doctor called and said, blood results are all good. On June 18th, we did the second blood draw. July 8th, the doctor's nurse calls me and said, again, all results are good. September, we did another blood draw, and I didn't hear anything from the office, so I called them on September 18th and the 21st, and I left a detailed message saying that I was kind of concerned because hemochromatosis does not go away. We've had it for the last 20 years, and I think he's getting very tired. He's not feeling well, and he needs the phlebotomy done. On October 1st, I received a call from his nurse saying that I needed to make an appointment. So I went ahead and made an appointment. I could not get a call back I did not speak to him once during this whole time. I could not get a call back from him. October 3rd, I received another call from his nurse, Erica Withers, and said that they couldn't find the results and that they were lost. So on the same day, over the phone, what I did was I filed a complaint with his office manager, Tanya Hill, to make her aware that there's a problem here. I need to see these results. The same day we went to the office, my husband and I both went to the office. We asked the front desk if we could pull his file and take a look at it, and could we see the lab results. We pulled the lab results out, and there was nothing in there that said anything about ferritin or iron.
Okay.
They tried to tell me that it was this MHC, and I said, no, I've been looking at these a long time. All I'm looking for is the ferritin and iron. It wasn't there. So on October 9th, I took my husband to an outside lab, Sonora Quest, because he really wasn't feeling good, and I know the signs of it. It was an independent lab, and they came back and called me and said that his level was 219. October 10th, I received a call from Erica Withers, again from his office, saying that the doctor never ran the test, only CBCs, and to come by the office and get new orders. So we did. October 15th, we had the blood drawn again. October 23rd, I received a message from Crystal Butchutz in his office, and this was in writing. She sent this in writing to me, and she said, it said, I have a copy of the iron panel, was received, and everything is within normal limits. At this point, I'm going, wait a minute. I know I have Sonora Labs telling me these things are way over the limits. And again, they're telling me they're within the limits. So then the next thing I do is on October 19th, I receive a letter from his office, a certified letter, stating that he's withdrawing care to my husband and that no other physician in Northwest will attend to my husband.
Okay.
I just have two more.
Oh, okay.
Just two more.
Okay.
October 24th, we go in there. We had a previous appointment set up, so I go in. All I wanted to do was ask a question. I wanted to see why. I was begging. I was saying, please have him call me back. No calls back. The nurses were just unbelievably rude. We get into the office. I go in, and they say I don't have an appointment. So I said, okay, I'm going to get United Healthcare on the phone. I get United Healthcare on the phone to try to help me. And they call the police on me. So I sit down in the office. I'm almost done. I sit down in the office. The police come in. The police are on my side. The police go up to the desk and tell his nurse to give me a copy of the records, which I have, that the police report. I have copies of all of this stuff. He printed it out. It showed there was no testing done. And then the police officer said, please give her an appointment this week so she could come in and talk to you. Because I explained you can't get through through the phone, through the healthcare system. We haven't trained for weeks. He got me an appointment the next day. I came in the next day with the appointment, approached him, and basically said, why didn't you return my calls? Why weren't you running the ferritin levels? I explained to him hemochromatosis can affect the organs if this is high, and we've had this for a long time. I tried to give him a chance to give me an answer. He basically waved his hands in the air and said to me, your husband is fine. I have other patients to attend. So at this point, I called United Healthcare, filed a complaint with Levante Quality Assurance Company, and they came back on December 27th and said that the doctor said that saturation and binding were not being done because he was assured that they were being monitored by Mr. Molesbury's previous doctor and determined to be stable. And he also stated that he planned to monitor them only once a year. In the same letter, Levante came back in my favor and said there is a quality of care concern here.
Okay.
They said they couldn't go any further.
You've given us enough information. I thank you for being so thorough, and I appreciate all the information you have done. And I'm sorry this has happened to your husband. I'm going to say that. Can I have a motion?
Yeah, I'm kind of, to quote the complainant's language, I'm kind of concerned myself. So I'm going to move for investigative hearing.
I have a motion by Mr. Landau to go to an investigative hearing. Do I have a second?
Second.
Second from Dr. Erbstrasser. Any discussion before we vote? All in favor signify by saying aye.
Aye.
All opposed, same sign. You will be notified, both the doctor and you as well. When we are going to go to a full investigative hearing, I would like you to be here again, too, as well. Thank you both for coming.
That's when we really delve into it. as compared to now, which is simply an overview.
You gave us some good information
Yeah.
today. Thank you very
Both
much.
did, yeah.
Okay. Thank you very much.
Thank you so much.
Okay. Justin, before we get into the investigative hearings, is there anybody with a license here that we need to do first, that needs to catch a plane or something like that?
Nothing that's been
Okay,
reported.
so we're ready to go straight into investigative hearings? All right. So we're going to go to number 6. This is review and discussion and action on investigative hearings, and the first one is DO-18-0066A, Michael James Tuttle, DO, license number 005688. Dr. Tuttle, could you come forward, please?
Dr.
Well-
Cunningham, the complainant, and her attorney are present as well.
Okay. Dr. Tuttle, could you have a seat right there? Who's Dr. Tuttle? Right here? Could you switch? Could you switch? We like him because that pole's in the way. That's the only. I'm sorry. Thank you. Could you swear in, Dr. Tuttle, please?
Raise your right hand. Do you solemnly swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
Yes.
Okay. Dr. Tuttle, could you introduce your counsel with you?
I'm Jim Goodwin. I represent Dr. Tuttle.
Dr. Tuttle, before we get started, could you give us a little bit about what your training is and the type of practice that you have now?
Sure. I went to medical school at Des Moines University in Iowa and attended Penn State University for residency training in Hershey, Pennsylvania. I've been here in the Valley practicing as an anesthesiologist for about 8 years. My practice varies from general anesthetic with adults and children, and also labor delivery, with all variety of anesthesia, pretty much.
All right. Thank you. Dr. Pry, I believe this is your case.
That is.
This case, Dr. Tuttle, was reviewed by a board-certified anesthesiologist. A 37-year-old female was scheduled for a spinal cord stimulator, and she stated that she thought she was going to have light anesthesia. In her complaint, she stated that when she awoke, she could not breathe or move, and the staff was scrambling and kept repeating to call for an ambulance. She states Dr. Tuttle told her several times to go to the ER. She states she did go to the ER with shortness of breath and cough and pain in her throat and was admitted and treated. She said she was treated for aspiration pneumonia and asthma. She states that she was told by the surgeon that she had stopped breathing after receiving propofol, then was trached, and they suctioned her out her lungs. She alleges that code blue was called. She was here last time and reiterated that she was trached. This was a 37-year-old female who was taken to outpatient surgery for a spinal cord stimulator on the 3rd of October, 2017. She had a history of asthma and reflux. She was given at 6:55 a.m. She was given Versed, oxygen, and propofol. She started having heavy secretions. She was suctioned and given a breathing treatment and albuterol. The procedure was abandoned, and the patient was taken to the PACU and given Decadron and SVNs. At 8:42, she was discharged, and the nurses reported that she was up and visiting with her daughter. She was told to go to the ER if she had any cough, wheezing, fever, or shortness of breath. Her vital signs were stable at the time of discharge, and her oxygen saturation was 98% at that time. She was not intubated. She was certainly not trached. She was suctioned after the propofol and Versed occurred. And Dr. Tuttle was concerned about an exacerbation of asthma, and of course he was also concerned that she may have aspirated, but there were no signs that she had aspirated. So she did go to the ER that same day with shortness of breath, severe throat pain, And she noted that she had taken a marijuana candy, which started her coughing spell and caused her to have more shortness of breath. She had no fever, but she was admitted to Mercy Gilbert with an asthma exacerbation triggered by intubation and vomiting, although she was not intubated. They were concerned about aspiration. They started her on a prednisone taper, gave her antibiotics and albuterol. They discharged her 2 days later with a cough syrup with codeine, and her chest x-ray was negative. She did not have aspiration pneumonia. She did have some bronchoconstriction that was treated with steroids and a bronchodilator.
Okay. Doctor, you heard the brief review here. Would you like to comment?
Well, anytime you have a patient who's in a prone position with an unprotected airway and they start coughing, as an anesthesiologist, your first concern is to protect and secure that airway. Make certain and evaluate for aspiration pneumonia, which would be one of the not necessarily the worst case scenario, but something that would require immediate action. This is a case that required a patient to be able to communicate with the surgical staff in order to confirm proper lead placement. So I could not, in good faith, sedate her any further to blunt her cough and airway protective reflexes for a few reasons. One, because she's in prone position and I need her to protect her own airway and to continue to breathe spontaneously. And the second one is to confirm lead placement with the surgical staff. Once she started coughing, I spoke with the surgeon. I said, if she continues this, I cannot further sedate her for these reasons, and he understood. And at that point, and he could obviously not continue to proceed working near the spinal cord with a patient who continues to cough. So I told him that I really need to cancel this case, at least for a short period, to make sure she's stable. And so that's what we did. We sat her up. I suctioned her oral pharynx with the 8-hour suction, and she remained in sitting position. Vital signs were stable. Of course, there was no trach. It appeared more and more that this was an exacerbation of asthma, not that there was no aspiration that had occurred. And so I instructed the recovery nurses to hold her, to monitor her, make sure she's breathing okay and appropriate to go home before she's discharged. And I even spoke to her and said, if you have any shortness of breath or any asthma symptoms, don't hesitate to go to the emergency room if that be the case. But all criteria were, the nurses really went above and beyond in making certain that she was okay to go home before she was discharged. They followed all criteria that are necessary and indicated before sending a patient home, which they did, and the case was canceled.
Did you hear she had been admitted that same day?
I called her a few days later to check up on her, see how she was doing. I did feel bad the case was canceled. This is a patient who's in chronic pain, and if her pain can be alleviated with a procedure, a relatively simple procedure, then we always want to help patients in any way possible. So I did feel bad that she wasn't able to proceed with the procedure. Called her to see how she was doing. She said that she was diagnosed with aspiration pneumonia, and I was surprised by this. Later found out that wasn't correct, but it was a concern, and anyway, that was pretty much the extent of it.
Okay. Questions from other board members?
Yeah. How did the surgeon react to you after you canceled the case?
He was very, very fine with it. He understood.
Good.
I mean, he knows he can't operate on a patient that's moving, and it pushes the patient at unnecessary risk. It was a conservative call, but we had to be conservative. I mean, the patient safety is much, much more important than an elective procedure.
I have one question. Go ahead. Doctor, you You stated a moment ago that you later found out diagnosis of aspirational pneumonia was not made.
Right. Where did I receive all the paperwork from? Was it from?
I suspect that came from paperwork that we provided as we were going through the case for the board. I don't know for sure, though.
I received the chart from, I guess, from the board, and that was paperwork from the emergency room where she was
Okay.
received care.
Dr. Where was that?
And of course, it was on their differential diagnosis as it was mine.
We always provide the physician
Right.
with the medical records and all the materials that we have prior to them coming for the investigative hearing.
Right, and it was from the hospital records, did not show a diagnosis?
Correct. The chest X-ray was clear.
Had there been I don't know whether this is important or not, but aspiration does happen. It does happen, and you can't always predict it, you can't always prevent it, but it does happen, and most importantly is that when it does occur, that you're prepared and you treat it appropriately. In this case, it did not happen, and there was no code blue, there was no tracheostomy, of course.
And may I interject? I think the reason that she may have gotten the impression that she had a code blue is her medical records, she told the nursing staff that she had an allergic reaction to Demerol and penicillin, and she noted that her reaction was a code blue, and they wrote that in the medical record. So my guess is if she got her medical records, she may have seen code blue written down, but it was just the nursing staff had written what she had said about her previous allergic reaction, but she did not have a code blue.
And if there were a code blue, this isn't something that would be handled on an outpatient basis. If there was a code blue, she would be taken by ambulance with me to hospital.
Right.
Any other questions from other board members? All right. Do you want to should we just let them stay there and have the complainant come up?
Yeah,
Let's have the complainant come over here. Is the complainant here? All right. Have a seat right over there. All right. Welcome. Just have a seat right there. All right. Can you swear the complainant in, please?
Raise your right hand. Do you solemnly swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
Yes.
And can you introduce who's with you?
This is my attorney, Kevin Chapman.
Kevin Chapman. Okay. You've heard what's been said here, and you've heard about the overview, you've heard the doctor speak so far. Do you have anything else that you'd like to add?
I was not aware that I did not have aspiration pneumonitis, number one. And number two, I do realize that people make mistakes. I make mistakes. Everybody makes mistakes. I was more frustrated with how the mistake was dealt with, in my personal opinion. Me, nor my family, nor my husband was told that I was sectioned out. And I feel that should have been something that should have been brought up, so that way I could have been aware later. By the time I got home, I could not breathe. I could not swallow. It was horrible.
Okay. Questions from board members? Mr. Landau.
No, I think the question I had, I'm not sure it's relevant, though listening. When in relationship to the time you went to the hospital, did you take the marijuana candy?
I want to say that I went home. I was extremely groggy. For it being a light sedation, it felt that it was very heavy. I went home, I laid down, I woke up feeling extremely uncomfortable, and I took a small piece of candy. Okay. So maybe, I don't remember, maybe an hour after I got home.
And how long after that did you have to go to the hospital?
3 hours, 2.5, 3 hours.
Was there any discussion between the relationship of your symptoms and the candy?
I'm sorry?
Was there any discussion with any of the medical providers about
I've been forthcoming with being a marijuana patient, absolutely. I told everybody at the surgical center as well as everybody at Mercy Gilbert Hospital.
Yeah, did anyone seem to think there was a relationship between the taking of the candy and your condition?
No.
Okay. Nothing else.
Okay. I wouldn't think there'd be any relationship either. Dr. Reese, do you have any questions?
No.
Okay.
No, I don't think there'd be any relation either,
Yeah.
and I'm truly sorry for your experience, too, in the fact they weren't able to complete the procedure. But I don't see an objective violation of standard of care. I would like to make a motion for executive dismissal.
Okay. So I have a motion. And again, I understand your frustration and what you went through. I don't want you to think that we are not feeling that. But we as a board, we have to look at, was there a violation of the standard of care? And so we have a motion for dismissal. I would support that as well from all the things that we've been read and so all the evidence that we have. Can I have a second?
I'll second the motion.
Second. Is there any discussion before we vote? Go ahead.
Yeah, I'm listening, I'm reading this, and I'm saying, yeah, I could see you're really frustrated. I'd be really frustrated because I'm looking forward, you're looking forward to the surgery. As the doctor said, you're looking forward to the relief you will hopefully get from your surgery. It's built up to the time you're doing it. Now you can't do it. And so I can see where you'd really be, number one, frustrated, number two, upset. And I have to echo what Dr. Madam said about our responsibility and what the law is in this, as your attorney will tell you, and what the proof is needed. And I, again, don't see a violation of the statute.
Any other discussion before we vote? No. Can I have a roll call, please?
Yes. Dr. Reese?
Yes.
Dr. Madam?
Aye.
Dr. Erbstrasser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. Case has been dismissed. Thank you both for coming. I wish you both the best, and thank you for taking your time to come down here.
Thank you.
Thank
I appreciate your time.
The next case is BDO-18-0031A, Kingwai Louis Dio, license number 007422. Dr. Louis, I hope I'm saying your name correctly. Could you please come forward, please?
I was going to mess up that pronunciation.
Please have a seat right there. Welcome. Could you please swear in the doctor, please?
Raise your right hand. Do you solemnly swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
Yes, I do.
And could you introduce your counsel with you, please?
This is Mr. Coucher. He's my representing attorney.
Welcome. Dr. Louis, could you tell us about your training and the type of practice that you have now?
So I completed my medical education at Western University of Health Sciences, that's in California. And then I did my psychiatry training in Visalia, California. And then I came to Tucson, and I just recently graduated from the Child and Adolescent Psychiatry Fellowship at the U of A.
Right.
Do you want to, I guess, I will be practicing inpatient and outpatient in Bakersfield, California, both adult and child population.
Okay. This is your case, I believe.
Yes.
Thanks.
How do you pronounce your name?
King Y.
And your last name?
Last name Lou is fine.
Lou?
Thank you.
Okay, thank you. Dr. Lou, this was reviewed by a board-certified psychiatrist.
Mm-hmm.
This was a 21-year-old female that was brought to the Crisis Response Center on petition by her family, who were concerned about her progressively worsening mental status. The family reports in their complaint they provided the nurse at the CRC with a detailed summary of events over time during the admission process to CRC. They stated that she had been awake for several days, had erratic behaviors since December, was a danger to herself, they felt. She was agitated, had delusions of persecution, and was hearing voices. The patient was seen by Dr. Liu, and our OMC felt that Dr. Liu may have fallen by below the standard of care in that a full and detailed assessment was not obtained. They felt that obtaining all necessary information to assess the needs and safety of a patient in crisis setting were not obtained. While the report of the patient to the physician showed she denied significant symptoms, the family was expressing concern that required her assessment and consideration in the decision-making process. We felt that those concerns included an erratic behavior including paranoid thinking and auditory hallucinations, substance abuse. She was using marijuana constantly. The nurse also described psychotic symptoms, behavior consistent with the family's description. And he felt that these issues were not fully assessed. Her urine was positive for THC and benzodiazepines upon screening, and there was no further discussion or assessment of this pertinent lab finding. He also felt that treatment should be implemented at a crisis facility, and this was not completed. The patient was discharged to the family without a crisis or safety plan, and he also felt that the discharge planning was lacking in that the patient and family were not provided psychoeducation, supportive or crisis response plans which would support them. Unfortunately, the patient attempted suicide on February 4th. This happened in January 27th. On February 4th, 2018, the same year, she attempted suicide and was at the time of the complaint was filed, was in the ICU with possible permanent damage due to self-inflicted injuries.
Okay. Dr. Liu, you've heard the review. Care to comment on what was just said?
So there are a few things I would like to speak to, regarding the case. Firstly, when I spoke to the patient, when I saw her that day, she did not demonstrate any type of psychotic symptoms that was noted. In the CRC setting where I worked at as a resident physician, our main goal is to determine if there's any imminent danger to self, others, or grave disability secondary to a mental illness. During that assessment, along with the staff at the CRC, we did not see that there was any signs of psychosis. However, we did believe that she would require some treatments, which she also agreed to, where we were able to come up with a discharge plan. Firstly, we had set up urgent enrollment with an outpatient agency, La Frontera, where they had staff come over to speak to her to make sure that her mental status is appropriate. Secondly, she also were informed with emergency numbers to call if there is any need for psychiatric care. And thirdly, she was discharged to a safe home, which is where she would reside with her grandmother and her mother as well. She was very coherent. She was cooperative. She was able to tell me exactly the events that led up to her admission to the CRC, which occurred actually a few days ago when she had a relationship breakup. She drove away for a few hours. She talked about substance use, which she was aware of, and she was able to come into the CRC that day, really because of mother's petition. And on the petition, it stated that she was a danger to self, but it was due to non-danger psychosis. And during the assessment, where she was there for approximately 8 to 9 hours, she did not demonstrate any signs of psychosis. I do believe that there could have been a more detailed assessment, but it would not be appropriate in the setting of a crisis response center, because that is not the role of the psychiatrist there.
So when you treated this patient, you were a resident at the time?
Yeah, I was a resident physician working under Dr. Rhodes.
So did he review this, Dr. Rhodes?
He did, and he agreed with the assessments and the information as well.
Okay. What year residents were you at that time?
I was a PGY 4, so I was first year into fellowship, which puts me as a PGY 4.
Dr. Reese.
Well, the fundamental question here is that
He's a board-certified psychiatrist, by the way.
That you had a patient come to your care or evaluation who had some kind of suicidal behavior, and what we would like to know is whether you were at fault for not investigating the suicidality thoroughly. So I would like you to tell us what you did to evaluate this individual's suicidality. How did you do that?
Right.
What questions did you ask? What questions did you ask the family? How did you arrive that she was safe to leave your facility?
Right. So according to the petition, there was no signs of suicidality. So she was a danger to self based on what mom's account was her driving away. For a few hours, she was accusatory of people, which was presenting more of psychosis. Questions that I always ask is previous attempts, family history. also current suicide ideation. These are the risk factors that we would look at when it comes to risk of self-harm. In addition to her family history of mental illness and things and so forth, and she did not demonstrate any of that. She, of course, at that time also verbalized that she does not have any suicidality, and that she was there based on what her family wanted her to do. Other things I would look at is obviously if there's any persecutory delusions, if there is any type of auditory hallucinations that are commanding type, which she denies all of it, and she didn't demonstrate any of that while she was on the unit.
So, what did you diagnose her as having, and
at that point, right? I'm sorry.
And what grade did you give her suicidality?
She was at that moment. I would say she was acute risk was probably low. Chronic risk was probably moderate due to substance use. There are some risk factors that she would have, which is her substance use. She was going through some stressors, which is a relationship breakup. However, she was very high functioning. She was a nursing student. She was recently hired. There were things that shows me that she was very high functioning previously, and therefore it didn't warrant any type of inpatient hospitalization.
And the subsequent suicidal attempt or behavior, what kind of lethality index did that have?
In terms of substance use?
No, in terms of the subsequent suicidal behavior. She left your facility and then she made a suicide attempt.
You know, unfortunately, I feel really bad about what happened, but once she was discharged, I really have no idea what occurred between...
And you have no idea what occurred in the
discharge and to the attempt. We set up an outpatient appointment. We had the phone numbers that she could call hotline, warm line, and also the phone number to the agency, but it didn't seem like she utilized it.
Can you read from your report what questions you asked, and other than no suicidal ideations intent with, can you read from your report what you put in referable to her suicidal behavior? Because that's the fundamental question. Did you evaluate it thoroughly?
Would you like to know the HPI or just the assessment?
Everything.
Everything, okay. So 200-year-old non-connected Hispanic female placed under AEA for the following: cries and says she hears voices and paranoid. On nursing assessment, patient presents with thought of death by a certain time. Patient admits to reporting delusions because I haven't slept for 3
Just for a second. Let's have you stop for a second. I've just been advised by our Attorney General that we should probably go into executive session because we're reading from her medical.
Oh, I'm sorry.
What do you think?
Well, I mean, I don't know that we could get at this case unless we hear what...
Okay, so, all right, so I'm going to make a motion that we go into executive session for obtaining medical information. Can I have a second? Second. All in favor, signify by saying aye.
Aye.
All of you, please step out and take your bag. Back at our executive session obtaining medical information, Dr. Rishi wanted to make a comment.
The comment I want to make is I think your overall evaluation was adequate for the circumstance.
Thank you.
The only point I'm trying to make is that, and this is more for the students back there as well as for you, that
Thank you, sir.
when you do any kind of suicide evaluation, don't say no suicidal plans or intent, because that doesn't tell us anything. It doesn't tell us anything about the patient. Otherwise, I think your evaluation was adequate for the situation. You had a supervisor who approved of it. You had, contrary to what our investigator felt, there was an adequate disposition plan. And it is a decision that you have to make. Should she go home and be with her parents or be with people that or try to petition? And that's a judgment call, and I think your judgment was as good as it could have been at the time. So just for board members, I only wanted to make the point about this narrow pitfall that most people fall into. They do not adequately investigate the suicidality with the questions that I pointed out before.
Thank you, Dr. Reese.
Any other questions, board members? I have a question.
I do too.
Go ahead.
Do I remember correctly, it was the mother who brought the patient in with the concern? Do you usually have a conversation with the family member or the person bringing the patient in?
So in the crisis response center, the collateral is usually done with the crisis workers, just because there's such a high flow of patients. Unless there's a specific concern, the crisis worker will communicate to us and say, hey, the family wants to talk to you. And throughout the admissions, it was never communicated to me that the patient's family had difficulties with having her home. And so I wasn't even aware of this until the complaint occurred. The discharge planning went smoothly. There was no opposition at that time.
But do I remember you saying correctly that the mother's concern was she was a danger to herself because she drove away?
Yeah, that was stated in the petition. That was part of the danger of her driving away.
So you did have information that the mother expressed a concern. However, it might not have been a very eloquent one.
Right, and so I talked to the patient about her driving away, and to me, that was reasonable for someone who's gone through a relationship breakup. They wanted time alone, and she was able to explain to me coherently, and so I didn't see that as a symptom.
Other questions from board members? My question is, if you had the same patient that came before you, how would you do it differently? Or would you do it the same?
I think the decision to discharge him would have been the same. I think the discharge plan would have been the same. Could it be possible that maybe there was improved communication between me and the crisis workers, per se? The setting, I think it does allow some of these things to occur because of how the flow of patients that was going on in the crisis response center. So that's what I would change. I would maybe communicate with the crisis worker a little more, or maybe just ask the question, hey, did the patient's family have any concerns? Instead of being in a passive role, I could have possibly been a little more proactive and to say, hey, what could I, is there any concerns?
Okay. Go ahead there, Mr. Landau.
Oh, so you listened to her, you took the answer. Did you not think she was a danger to herself or others? Or a danger to herself?
With her mental status at the time, she wasn't a high risk. I can't obviously guarantee that she's always going to have no risk. But when I have to weigh out whether or not she has to be hospitalized, I do have to take into account the history that I've taken. And if this is an individual who has no previous psychiatric history, who's been high functioning, who's worked recently, yes, she had a relationship breakup, and that can reasonably be a huge stressor for her acutely, that I believe that an outpatient treatment, given that she's also willing, will be more appropriate for her.
So did you think that I'm trying to avoid having everyone have to leave again, but do you think that the outpatient, the relationship breakup was the only reason for her.
Substance use as well. So, but these are things that substance use is not. I can't classify that as a reason to hospitalize her because of substance use, given that she's an adult. If it's a child and adolescent population, it'll be a totally different story. But because she was an adult, I think that I cannot, that's not my realm to decide, if that makes sense, her substance use.
Well, I think that's where another point where I'm going to disagree with you on, but we're not going to, I don't know if we need to get into it. My point is that, and maybe it's a layman's way of saying what Dr. Reese is saying, that you have to, it seems to me as not a physician, not a psychiatrist, that you have to take into consideration everything. It's a puzzle.
It is.
And it's a difficult puzzle. It doesn't come together easily.
I agree.
And try to take everything into consideration and then make an informed decision.
I agree.
Okay.
Any other question from board members?
I just want to comment that, it's these are really hard cases because you don't know the outcome.
Yes,
it's easy if somebody comes in and they're hallucinating, they have auditory. Well, that's easy, right?
Right.
And I think Dr. Reese really pinned on it that we sometimes document to protect ourselves, right? No suicidality or all of that. But you need to go beyond that. You need to ask those questions. Have you thought of killing yourself? Are you thinking about death? I mean, it's not saying, well, are you suicidal? I mean, that doesn't have any connection
concrete,
to it, right? And they're going to, well, no. But you got to think about, there's other cofactors there. So, but these are the cases that are really hard.
It is. I agree.
Yeah.
So how do board members feel? Do you think this is a letter of concern? Do you think this is
I feel that
more or less?
This has been a learning experience, hopefully. I think that I don't see any reason for anything punitive. So I'm torn between a letter of concern and dismissal. I wouldn't go any further than that. And I think that he was a resident. Everything was approved by his mentor. He wasn't working in a vacuum. There were a lot of other people involved in the case. It's a crisis center. The rules sometimes are different there than they would be in a private office. So I'm just going to throw out a dismissal.
Okay. What do you, Dr. Madam?
I would just like to say I do not want your job. I appreciate doing it, and I second that.
Okay.
Thank you.
And I'm going to tell you that, in my opinion, I agree with Dr. Reese. He was under the supervision of another physician. I hope you've learned a lot from this experience.
Yeah,
this is not pleasant coming down here. You know that.
Not, I mean, when I got the letter,
it's in the back. Also, understand this too. Even if you're a resident, you're not. You don't get a free card. Okay,
no.
You're still responsible for the care of the patient, and so, even if you are under the supervision of another physician, still it's your care, doctor. You have a license. Okay,
I understand.
And so, I hope that you take this really to heart because you have a long career ahead of you, and it will take. You have I call him my senior statesman, Dr. Reese. I couldn't get along on this board without him, so please take his advice and the other board members here. But I would support a dismissal as well. Can I have a motion?
Who was?
Dr. Reese, did I have a second?
Yes.
Dr. Madam. Any discussion before we vote? Go ahead, Dr. Reese. I mean, Mr. Madam. Mr. Landau. I'm sorry.
When Dr. Reese said she was debating between a dismissal and a letter of concern, my comment to myself was, well, what would the letter of concern be for? And I think Dr. Reese answered that question by the motion to dismiss, which I support. But I want to echo what Dr. Cunningham said, especially in your area where everything's amorphous, and really need to think through it and think kind of think ahead and consider what could happen, where it's going, and try to go beyond just the pieces and think about what potential pieces there can be. So I support the motion.
Go ahead.
I was just going to also say that all the things that Dr. Reese talked about, well, all the other questions you might want to ask, also document them.
Yeah. No,
Document them so
yes.
that, if, God forbid, something like this happens,
Right.
there's documentation.
Right. Thank you. It's a huge lesson for me. I cannot thank you guys enough for the decision.
Thanks, Dr. Prom. Can I have a roll call?
Yes. Dr. Reese?
Yes.
Dr. Maynard?
Aye.
Dr. Herbstresser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. It's dismissed. Good luck to you, Doctor.
Thank you. Thank you.
Thank you, members.
Thank you. Anybody need a break, or do you want to go out next?
Let's take a
Okay.
5-minute break.
We're going to take a 5-minute break. We'll be right back, okay? We're back in session. Before we go back into our investigative hearing, we have a very important, esteemed guest here, Dr. Steingard, and he is the chair of the Federation of Medical Boards. He was the past chair of this board as well, and Mr. Landau is also the treasurer of the Federation of Medical Boards, and he just wanted to give us an update, so we're going to give him the floor here. Welcome.
Thank you. Thank you very much, and thank you for this brief interruption. I will not take a long time and just try and get out, but it's good to be back. It's good to see everybody here looking well. Things are going well at the Federation. We are very busy. I have a couple of my medical students that are rotating with me, and they don't see very much of me, but I'm actually here. Actually, both of them are very good medical students. Jack and Ryan both told me they're number one in their class. I'm just not sure who's right, so they can figure that out. But a very busy year. As you guys know, the Federation is working for all of our state medical boards, and that's what we do, and we keep that in mind at all of our meetings. I want to thank, obviously, Jerry is our treasurer and has done a fine job. And we are in very good position that way. And I want to thank Dr. Reese, who's part of our impairment committee, and we have a work group working on revising our impairment guidelines. He did a great job. It was really a pleasure having him. And things are going well. We have two work groups. One is on impairment, and the other one is looking at the lifeline of a doctor's career as medical practice, from residency all the way to the end of their careers, and looking at mitigating factors and things that could impair them. The other work group we still have is our physician sexual misconduct work group, and that is in its second year under our immediate past chair, Pat King. That's wrapping up, actually. We're about to go into our starting to write the paper that's going to come out, and House of Delegates will be voting on that. So those are all going very well. The other thing we're doing that I think you might find interesting is a project called BACE, B-A-C-E, which is basically looking at trying to standardize language between boards. So, for example, if our board here rights for unprofessional conduct, what does that mean? And can we use better language to describe what that unprofessional conduct was, and figure out ways of standardizing it across medical board jurisdictions so that it makes more sense to other boards if a doctor changes states and goes to a different jurisdiction. So that's an ongoing effort. That's extremely tedious because oftentimes these are not things that these have to be hand done, because the cases are often written out in language that doesn't necessarily lend itself to keywords, as you might put in an algorithm. So that one's very interesting. So there are just some interesting things going on, but there was two areas I wanted to bring to your attention that I was hoping you could look into at some future date. The first one is score reporting. As you may know, I know Jerry knows, the U.S. medical licensing exam, which the Federation co-owns, is in the process of looking at score reporting. And right now, many of our osteopathic medical students, along with all of the allopathic medical students, take the U.S. medical licensing exam. One of the complaints is that the use of the medical licensing exam has been subverted by program directors to rank students, and how they may get a residency would be based on these tests, particularly Part 1 and Part 2. That may work in our favor, that may work in our disfavor, but for our osteopathic students who are forced to take COMLEX, that's their exam, oftentimes they feel compelled to take USMLE as well. Technically speaking, they shouldn't have to, but there is a feeling amongst those students that they have to take this exam or they're not competitive within the environment of specific programs, perhaps programs that might be considered more competitive. We, at the Federation, although we co-own the USMLE, and we have a partnership, but not a business partnership, but we certainly work with the MBOME who does the COMLEX, we at the Federation feel that that's not a necessary test for them to take. It puts more pressure, it puts more expense on our osteopathic students that they shouldn't have to bear. In other words, they pay, oftentimes feeling like they have to pay twice, plus it's an extraordinarily high-stakes exam twice. And so we're looking at score reporting. And are there ways to change that to allow all the medical students, MD and DO, a fair shot? And if they go to a particular residency, why would that be the only criteria that they're judged upon? So what I was asking for you is this. We haven't come up to a decision yet. As Jerry knows, we virtually talk about it every board meeting. But what I was hoping was, let me go back. Whatever we do at the USMLE will have a direct effect on our osteopathic students in two ways. Number one, it will affect them if they continue to take the USMLE. But number two, the MBOME, our osteopathic medical examiners, are going to change their tests to keep consistent with the USMLE. They don't want two separate score reporting systems. So it's going to be extremely important whatever they do. So my request to you is begin the discussion of where you think this might go. I will try and get you, if you're interested, I'll try and get you some of the information that we've gotten. We put a query out we had a program called INCUS, which looked at the score reporting back in March. We sent out a summary of the meeting, and we asked for comments. We got 22,000 comments from people. Some of them were entire organizations that put a committee together to come up with comments on this. So it's a very big deal. But what I'm asking our medical boards to do is think about it. Think about what would help us. Most medical boards just want to know if they passed or if they did not pass. But if there's more to it, if you feel like we have a bigger responsibility, then please talk about it, make your decisions. I'll try and get you whatever information you might need. And hopefully we can add that to the conversation. And certainly we want to have our colleagues at MBOME aware of what this board feels, because obviously they work for our boards.
Can I comment on that?
Of course.
A second. Under Dr. Steingard and as well as previous chairs, the Federation has expanded its role in the House of Medicine. And we are in existence to talk about or to deal with licensing and regulation. But I think we have rapidly learned that licensing and regulation is more than just here's your license or you did something wrong or right. Issues such as the scoring, physician burnout, sexual boundaries, physician impairment that Dr. Steiner and Dr. Reese are working on, they're all part of medical regulation. And in fact, they're prophylactic, they're preventive, but they're also looking ahead, and which will ultimately, with the goal of helping the physician and helping the patient and protecting the public. And I think while the Federation is wisely looking at these areas, I think our medical boards, including our board, can do exactly the same thing. And Dr. Steingard's comments, I think, are really appropriate in the sense that it should make our board, as well as other boards, think about what we can do in this and in other areas to maybe expand our presence in regulation and licensing to better protect the public and to assist the physician, which all comes together. So I think it's a really good idea.
Thank you.
I think Gene's made a point that this isn't on the agenda, but clearly we can have
Dr. Senger's here for call to the public, but I just didn't want the board to engage.
And but we have information, and so certainly if we want to move forward with this, we could put this on the agenda to have more discussion on our next visit then on it. Does that sound appropriate then to other board members? Okay.
Yeah. And I'll give you one more thing, and this is more an aspirational thing, and that's augmented or artificial intelligence. As you know, we're seeing artificial intelligence or augmented intelligence, or AI, we'll call it that, in all facets of life. It has not escaped the regulatory vision. In particular, we are looking at how it might affect our regulatory approaches. Right now we have a task force on AI. And the task force will not be reporting to the House of Delegates. It will only report to the Board of Directors for this year. Perhaps in the future we will put a work group together that will actually come up with regulatory approaches. My ask to you is at some point in the future, I'd like you to take a look at how AI may affect you. These are things where we can actually bring our people in for a meeting. If you guys have some time for a retreat, maybe even include our medical board colleagues as a dual meeting, something we haven't done in the past, but this one probably is worth it. It doesn't just affect, it affects so many different facets, but one of them is we talk about team-based care, and if, for example, if a device goes bad, who's in charge? Who's at fault? Also getting data, and one of the issues that we're looking at now is a thing called right touch regulation, which is our current system is complaint based, but what if we had data to look at doctors and find out if they were predictive to have errors in their practice? Could we possibly head that off at the pass? So those are the things that I had. Thank you for the time. I apologize to our investigative hearings that are waiting, but we will certainly meet back here in the future.
Can I ask one question, Gene, for an the only question I had is, could you possibly get us more information, maybe we can put this on the agenda next time, about medical marijuana and physicians and recreational marijuana and how the Federation views that?
I will be happy to.
Okay.
Thank you. My pleasure.
If I can make one comment, too. This is the...
Lead off.
Yeah.
Huh?
Oh, she's just gritting her teeth. Don't make the comment.
That's fine. She'll survive. This is the first time in the history of the Federation where the president and the chairman and the treasurer come from the same board.
And that's true.
Yeah, and from and here it's in Arizona and this board.
Thank you for both your work. Thank you, Scott.
Thank you, guys, and thank you for giving me the time.
See you tonight.
All right. Now we're back to investigative hearings. This is C, DO-18-0142C, John Darrell Thompson, DO, license number 4022. Dr. Thompson, could you come forward? Please have a seat there. Welcome. Could you swear in Dr. Thompson for us, please?
Please raise your hand. Do you solemnly swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
I do.
And could you introduce your counsel with you as well?
This is my representative attorney, Mr. King.
Welcome, Mr. King.
Thank you.
Could you also, Dr. Thompson, tell us about your training and the type of practice you have now?
Excuse me, is the complainant here?
I don't know. Is the complainant here?
There's one complainant present. The other complainant would like to be available by phone.
Okay. Do you want to go ahead and get them? When are you going ahead and dial them in? Before we get to just a minute here.
Hello?
Yes, this is the Arizona Osteopathic Board ready to proceed in the investigative hearing. Just a reminder, please use your initials only to identify yourself to protect your identity, okay?
Okay. Do you want to just tell him we're getting started? Because I'm not over. Or I can come over there.
Get some exercise.
Yeah. Hi, sir. This is Dr. This is Dr. Cunningham. I'm the chair of the board. So just listen in. We just started our hearing, and when we want you to speak, we'll have you speak, sir. Okay? Thank you. You let me know. All right. Thank you, sir. All right. Go ahead, Dr. Thompson. You were about to say about your training and the type of practice you have now.
Sure, I'm a graduate of the Kirksville College of Osteopathic Medicine.
Talk right into the microphone, please.
I'm a graduate of Kirksville College of Osteopathic Medicine in Kirksville, Missouri. I did my internship at Community General Osteopathic Hospital in Harrisburg, Pennsylvania. Completed a residency in orthopedic surgery through the health system in Harrisburg, Pennsylvania. I then trained through the residency. I was an attending trainer of that program for the residents here in Harrisburg at Community General Osteopathic Hospital. Transferred here, back home, completed a fellowship in adult reconstruction at the Core Institute, and I'm currently practicing here, predominantly adult reconstruction. I've been in practice for 19 years.
Okay, thank you, sir. Dr. Pry, I believe this is your case.
Yes. And Dr. Thompson, this was reviewed by a board-certified orthopedic surgeon. This involved an 86-year-old male that had a left patellar fracture after a ground-level fall occurring on December 8, 2017. Dr. Thompson performed an ORIF of a comminuted and displaced patellar fracture on December 19th, 2000. It says 2020. He was just
for a second, could you tell for the public what an ORIF is?
Open reduction internal fixation.
Very good.
Of a comminuted and displaced patellar fracture, and this was done on the 20th of December 2017. The patient was discharged to a rehab center on the 25th of December with instructions for fracture follow-up at the Core Institute on January 11th, 2018. Instructions for non-weight bearing and full use of an immobilizer. Instructions were also given not to remove the surgical drainings until follow-up with an orthopedic surgeon on the 11th of January. Unfortunately, the patient developed a low-grade fever while he was at Grandview, and then the lab found that he had an elevated white count and a low sodium level. The nurse also noted a buttock wound and some confusion. The patient was sent to the emergency room at Benardell Webb, where he was admitted. He was found to be septic. The patient was cared for at that point by Dr. Matthew Kinsley, who is also works for Core. The patient was found to have a wound dehiscence and purulent drainage from the knee. The patient was seen by a infectious disease and started on vancomycin. They also recommended a surgical incision and drainage. The patient began to develop other signs of septic shock. Blood cultures showed methicillin-sensitive Staph aureus. Medical treatment was instituted and the patient was taken to the ICU. An IND was performed by another orthopedic surgeon, Dr. Hadi, on January 5th. The second surgical debridement was performed by another doctor, Dr. Brown, on the 14th of January. And this included evacuation of a thigh abscess and debridement of anterior soft tissues. They also had to do a flap. The patient went on to, they also tried a wound vac. He had an extended stay and multiple challenges, and unfortunately the patient passed away on February 15th, 2018, at an extended care facility. Our medical consultant that reviewed this case felt that there were areas that the standard of care was deviated. The only one that actually really, I think, involves Dr. Thompson was that they didn't feel like the postoperative orthopedic follow-up was appropriate. The patient wasn't scheduled to be seen in the back in the office for 3 weeks postoperatively, and unfortunately, the care at the rehab center there was no orthopedic treatment there at all, and they didn't really note the signs of infection and sepsis as early as they may have had the patient been seen by an orthopedic surgeon.
Okay. Doctor, you heard the brief review from Dr. Prong. Would you care to comment, please?
I'll just make some comments about the kind of a course to fill in some time events that kind of make you all familiar with the case. Essentially, the initial insult was on December the 8th, in which he had fallen directly upon his knee and sustained a comminuted fracture. He was on Plavix, a blood thinner, developed an abrasion and a large hematoma. He was seen in an emergency department, placed in an immobilizer, and referred to the office. He was seen by one of my physician assistants approximately 3 days later. At that point, x-rays were performed, and with review of that, based on the patient's medical history, comorbidities, the position of the components, and his ability to straight leg raise, we elected to treat this initially non-operatively, and decided to follow up in a week for repeat x-rays to see if there's any change in position. He subsequently was seen back into the office a week later. Repeat x-rays were performed, and at that point, this was J.K. had seen one of my PAs, the J.K.'s daughter, who is a nurse, as well as J.K.'s son, who is an emergency room physician, were available. The J.K.'s son was available by phone. At that point, we discussed the case. The concern for their father was his ability to mobilize actively and care for his wife. At that point, J.K.'s son had reviewed orthopedic literature, and based upon the displacement of the fragments, there was indication for surgery. And based on those criteria, definitely there was. So based on the hopeful ability to maintain the care of his wife, increase his mobility, prevent hopefully long-term sequelae from the fracture, they had wished to proceed with the surgery. At that point, based on some discussions, I wanted to try to empathize with the family and the son to do the professional courtesy and try to expedite this case. He was subsequently referred from my office to the hospital to be seen by the internist to undergo medical clearance, understanding that the patient has cardiomyopathy, ejection fraction of 20%, on Plavix, had 2 prior myocardial infarctions. Patient underwent medical clearance. The subsequent day, underwent an open reduction atrial fixation using a standard tension band wiring technique. It's been around for years and years. The case was, unfortunately, quite simple, very basic. The only thing that was unique about the case is he did have a venous tourniquet, which means that with use of the tourniquet, I could only use it for 3 minutes because it wasn't functional, because unfortunately his arteries weren't really collapsible to stop the blood flow. So as a result, the arterial blood goes forward, the venous blood is unable to get back, you get extra bleeding actually. So you let the tourniquet down, and ironically you get little or no bleeding subsequently. Proceeded with the case. Patient was placed in an immobilizer with a sterile dressing, was seen in the hospital daily. Normally a case like this can be performed possibly as an outpatient or 23-hour observation. The patient did have a prolonged hospitalization secondary to hyponatremia and was followed by myself and my PA daily until discharged. Throughout the course, he had a normal white blood count, They did treat the hyponatremia until it was improved and subsequently referred to a care center. He was maintained as non-weight bearing because prior to that he was weight bearing with his brace, which you worry about displacement. And so hopefully to preserve it, even though in general the soft tissue around the fracture was maintained. That was for the stability. His follow-up was to be in 2 to 3 weeks for the staple removal. This is standard of care. I do total joint replacements, and that's how long it is, particularly with him because of his poor tissue perfusion. He was a vasculopath, poor ejection fracture, etc. Unfortunately, after he was discharged, I essentially did not participate much in his care. The week leading up to his admission to the hospital, he did have, unfortunately, events of low blood pressure, increase in white blood count, hyponatremia again. This was somewhat delayed. They repeated the values. They were low. He was subsequently readmitted to a hospital which I normally don't go to, in which my colleagues cover. And just so happens on the week that he did go to the hospital, I was on vacation the whole week. So I was not available. So he's at another facility, treated appropriately by my partner, Dr. Hadi, and our physician assistants, and then subsequently somewhat improved. I won't go on to the additional subsequent events, but also on a subsequent IND by my partner, Dr. Brown. But unfortunately, between the first IND and the second IND, dramatic decline in the vascular ability to the skin in that area with necrosis and slough. Patient had the poor ability to fight the infection. And unfortunately, it's just a horrible outcome at the very end.
Question from board members.
Do you want to hear from...
You have to hear from
Okay, you want to hear
others. Complaint here too.
And there's another complaint here too, is that correct? You want to come forward and have a seat right up here? Sir, this is Dr. Cunningham again, and you want to swear him in? You want to swear him in?
Can you raise your right hand?
Sure, yes. Are you there, sir?
Yes.
Okay, go ahead.
Do you solemnly swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
Yes.
You heard from Dr. Thompson. Is there anything that you would like to add, sir?
Yes. First off, did he have to attend this meeting, or was this voluntary? He's there.
I'm sorry, what?
Was it mandatory for him to go to this meeting, or was he there voluntarily?
Yes.
Okay. All right. I am the youngest son of the deceased. My initials are TK. I was also his medical power of attorney, and I'm still my mom's medical power of attorney. And my father died on February 15th, as was mentioned, directly and indirectly due to multidisciplinary failures, medical malpractice, and hospital system dysfunction. Banner Del Webb Hospital killed my dad. My dad died directly due to multiple lapses in standard of care from multiple providers, including an ER doctor, hospitalist, infectious disease specialists, nurses, and primarily the core orthopedic group privileged to provide orthopedic services at Banner Del E. Webb Hospital. You guys are aware of the surgery. I'm not going to rehash that one. But my dad did come to the ER on 3 January 2018. We already know he had low-grade fever. He was noted to have a white count of 16,000. And he had surgery 2 weeks prior. So actually one of the hospitalists, the initial hospitalist, did a history and physical on my dad on the morning of the 4th of January, about 5:30. He let us know. Dr. Matthew Kisley, I'm not sure how to pronounce that. Anyway, he knew of my dad having an elevated white count of 16. He knew of the recent surgery, and he actually wrote in his note that my dad was having worsening pain in his knee, where the surgery was. And he never examined my dad's knee. The ER doctor never did examine my dad's knee either. Next, my dad was in the ER for over 24 hours due to inefficiencies in the hospital creating a bed. in the ICU for him. Oh, let me say one more thing because you guys don't know, but I'm a board-certified emergency medicine physician, so I'm going to kind of say abbreviations sometimes, and let me know if you want me to spell it out.
That's fine.
So he was in the ER for 24 hours. This delayed antibiotics and orthopedic evaluation. He was seen by an ortho PA, AZDO, at 2 p.m. the day after. He came in at 10 p.m. at night on the 3rd. He was seen by the ortho provider at 2 p.m. the next day, and that's when they noticed the infected knee joint. And their note was countersigned by a Stephen Werner 4 days later, and that Dr. Werner said, agrees with above. So apparently Dr. Werner agreed with the profound delay in getting this evaluation. The profound delay in my dad receiving antibiotics 18 hours after he arrived at the ER, standards less than 3, and the ridiculous delay in performing surgery on a patient with a septic knee joint that has septic shock. My dad did not get antibiotics, as I said, for 18 hours after arrival in the ER. 18 hours, the standard for surviving sepsis is less than 3. My dad did not get surgery to treat his septic knee joint until over 30 hours after arriving to the ER, despite having documented septic shock and a septic joint for over half of that time. In fact, 21 of 24 mean arterial pressures the night before surgery were below 65, so he was in septic shock all night before that surgery. And he was cleared by the nephrologist and the hospitalist to go to surgery the day before, and ortho waited. Jack had an initial 4-day stay in the ICU due to the deficiencies above, which led to profound weakness, setting him up for additional illness later. If not for the above, the ICU stay may have not actually happened at all, other than for his low sodium. Nursing staff documented evidence of possible reinfection of the IND wound multiple times, starting on the 6th of January. Surgery was the 5th. Starting on the 6th, they started documenting the wound was not normal. Here's one example. This is on the 9th of January. This was 3 days after the surgery. She described the wound color as pink, red, and yellow. There was drainage present. The exudate amount was moderate. The exit type was purulent. The odor was faint. The surrounding tissue had erythema and was purple. And the wound status deteriorating. I'll ask Dr. Thompson in a little bit what he thinks about that, but not yet. Next. Ortho services never rounded on my dad on the 8th of January. Not the PA, not the surgeon, nobody. Not one note on the 8th of January that they came and even saw him. And then on the 9th of January, they discovered that a pico drain that they had since post-op wasn't functioning. So it could have stopped the day before, but nobody checked. Dr. Brian Morse, who was also a DO, examined my dad as a hospitalist twice, on the 9th and the 10th of January. And Dr. Morse noted my dad complaining of worsening knee pain after the surgery, of course, for the washout. And Dr. Morse didn't even perform an extremity exam either day. It's the typical don't examine the patient, commit malpractice that happens every day at the hospital by the providers. Next. Orthopedic surgeons never rounded on my dad from the date of surgery, the 5th of January, until the 12th of January. From the 6th to the 12th, not one orthopedic surgeon wrote a note. Not one orthopedic surgeon countersigned the PA's note. They were flying by the seat of their pants without any supervision for 6 days. For 5 days, my dad had an elevated white blood cell count greater than 20, normals 4 to 10. Before his original washout, it was 14, so it's greater than 20 now for 5 days in a row. And the ortho PAs never write in their assessment that they were even aware of the elevated white count. Every doctor, including the infectious disease doctor, deferred to the least trained provider in the care team, the physician assistant, regarding the condition of my dad's surgical wound. My dad's cardiologist even performed a transesophageal echocardiogram looking for endocarditis, since ortho was not pointing at the knee as a source, without a single doctor ever documenting a wound exam below the dressing from 6 to 12 January. Unexcusable. Next, infectious disease doctor and infection specialist never looked at my dad's wound below the dressing until the nurse told him to on January 13th. Again, the surgery was on the 5th. Too numerous to count opportunities to detect reinfection were missed, despite nurses documenting abnormalities on all assessments after 6 January. This led to recurrent septic shock on 13th January, resulted in respiratory failure, intubation, pneumonia, C. diff infection due to stronger antibiotics, feeding tube, trach, transferred to the long-term acute care hospital where my dad died 2 weeks later due to the many insults he endured and was unable to recover from by Daniel Del Webb Hospital. Now, I believe that if Jack's knee wound was intervened upon when the infection began to present itself initially on the 3rd of January in the ER, and also between the 6th and the 9th of January right after the surgery for the washout, he would have improved. He would have avoided the respiratory failure, septic shock on the morning of January 14th, the eventual C. diff infection and intubation, multiple pressure wounds due to the prolonged ICU stay. He would have left the hospital in a few days without a ventilator with a strong chance of recovery. But huge lapses in standard of care, gross medical malpractice from Dr. Thompson's post-op complication, and I understand complications and infections happen, from the ER and initial hospitalist not examining his knee at all, to nurses not communicating their concerning wound exam findings to their doctors, or the doctors just not looking at the nurse's notes, which is something they should do, to no ortho surgeon ever rounding on my dad from 6 to 12 January, to no ortho provider at all, no PA even rounding on him on the 8th of January, the lack of perception of the ortho PAs on what worrisome signs are for wound reinfection, their inability to recognize an obvious, grossly infected wound, their failure to communicate deviations from the norm to their surgeons, such as drainage, failing pico drains, eschar, persisting leukocytosis, that they did not even address they didn't even address this in their assessment and plans, and an overall lackadaisical attitude of the core orthopedic surgery group when confronted with a patient in septic shock with an obvious septic joint, not once, but twice, delaying surgery to tomorrow, all contributed to the demise and eventual death of my father. I don't know if my sisters mentioned it, but my dad was the youngest of 6 siblings, and although he was 86, all of his siblings lived to 90 plus. And he was my mom's primary caregiver. He was completely mentally intact. He was a fighter pilot, and he remembered things in our conversations that I had long forgotten. Banner Del Webb's providers failed Jack, and they killed my dad. I regret that I was not able to recognize their incompetence at the time. I figured they would have been on their A game with an ER doctor's son checking in just about every day. But if that's their A game, I feel sorry for the rest of the patients in that hospital and the rest of the patients that Core Orthopedics is taking care of. Now, I got 4 or 5 final bullets I wanted to give to the board, if you can please give me that time.
Sure.
The first is I want the board to please acknowledge that Dr. Thompson and his other colleagues at Core had dangerously inadequate physician oversight of their PAs, which led to my father's reinfection being missed for 5 days. Not one ortho doctor note in my dad's chart for 1 week after his first surgery. I know the Arizona Medical Board, and I'm sure Osteopathic Board is about the same. It allows ortho doctors to delegate to their PAs, which is a great convenience, but with that convenience comes responsibility. And that responsibility is that if the PA commits malpractice, the doctor is responsible. And in addition, a physician can also be responsible if the actions of the PA are done when there is a failure to supervise properly. And when there is not a note from the doctor for a week and no countersignature, please ask yourself, is that proper PA supervision? My next bullet, that was the first, is 5. I want to find out why Dr. Thompson never rounded on my dad once after his surgery. He said he was on vacation for a week. My dad was in the hospital for a month. He had no ownership, no professionalism. He gets, the surgeons gloat and are proud when they have their successes, but when they have failures, they're nowhere to be found. And Dr. Thompson was nowhere to be found on his failure here. The third bullet, I want to find out if Dr. Thompson got paid for the procedure that he did that resulted eventually in my dad's death. And if so, does he think that's right? Because I would prefer that he donate that money to a charity of our choice, because I don't think he deserves that money. The fourth bullet, I don't know if the board was given the photographs that my sister had given. Did you give those yet? Did you get those yet?
I don't recall seeing those.
I haven't spoken. That's what I have.
If my sister can at least hand out the wound infection picture.
Okay. Well, go ahead and go through your bullets, sir.
Okay. I want Dr. Thompson to have one of these pictures of his own, and I think she might have made a couple other copies for the board to look at. This is a picture of my dad's infected knee. It looks awful, and you may think that it was what it looked like when he came to the ER on the 3rd of January. But no, this is what the core orthopedic group allowed to happen to my dad's knee in the hospital. They allowed that to happen in the hospital on their watch. Remember, 4 days prior, the nurse said, pink, red, yellow, drainage present, moderate, turbulent drainage, faint odor, erythema, purple, deteriorating wound. This is 4 days later. And even the PA who wrote their note 2 hours after that picture was taken said, eschar, no drainage, where you can obviously see there is surgical hardware protruding from the wound with pus. And it doesn't take a doctor to recognize that. Next bullet. I want Dr. Thompson to formally apologize to my mom, who I think deserves an apology. I hope that he would do this on his own. If the board can order him to do that, if he won't do it voluntarily, I would ask for that. I think that his widow deserves an apology for what happened. And in addition, I think any sibling of mine who wants an apology should get one as well, starting with me, but not yet. And my last bullet is I want to remind the board that there were several DOs involved with this case, and one of them was Dr. Matthew Nisley, who was the initial hospitalist, and I mentioned in my bullets earlier that knowing he had low-grade fever, white count, recent surgery, complaining of worsening knee pain, never examined his knee. And I'm sorry, but I'm an ER doctor, and I would get sued for that, and I would get successfully sued for medical malpractice. So I just want to make sure the board is going to give him his day in this hearing room as well. Because I did make a Levanta quality of care complaint last November. They replied a little sooner than y'all, but I'm glad you guys finally have this hearing. And Levanta actually had their medical director, Dr. Stein, do the quality of care review, and they particularly found that Dr. Nisley's care was, they said there was a quality of care concern identified with his care. So I want to make sure that you guys are aware of that. And again, my biggest concern for Dr. Thompson is he is an owner of this outcome, because he benefits from these mid-levels rounding on his cases so he can go back to the OR and make more money. But he has to have responsibility over them. They have to be supervised. These are his PAs just as much as they were Dr. Hattie's and Dr. Brown's. Even though he wasn't in that hospital, he has privileges there, and he needs to be responsible for these PAs, particularly because it was his post-op complication that caused my dad to die. And that's all I have. Thank you for listening.
Thank you, sir. Thank you so much for you. And we're going to talk to your sister here next. If you just stay on standby there, of course. Okay.
Yeah, I'd ask Doctor, you stay on the line because I'm going to have some questions.
Stand by. Yeah.
Okay.
Don't go away. All right. And then I understand you're the daughter. Is that correct?
That's correct. I work at Del
And
Webb
would you go ahead
Hospital.
and swear her in too, please?
Raise your right hand. Do you solemnly swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth?
Yes.
Do you have some pictures? Justin, will you grab those from her, please?
If you can just give us your name for the record.
Yeah, for the record.
My
Or
initials. CW.
Thank you.
Yeah. So I am an ultrasound technologist over at Del Webb, and so I was able to visit my dad frequently, several times a day. I really have nothing more to add than what my brother has said, other than I just wanted you guys to see the evidence of a man who was extremely mobile. He was an agile, happy man. The first three pictures are the pre-op pictures. The fourth picture was post-op, where all these pictures, he's a very happy, lively man. The fifth picture shows the gangrenous knee, which is clear evidence of medical negligence. The sixth picture is the debrided knee, and then the progression goes where he was intubated, extubated, re-intubated, and then trached. So I just wanted you guys to see that this person was an extremely, it shouldn't have happened this way. He wasn't a sick man who was on his deathbed before this happened. He was very lively, and that's why I included other pictures of him in those as well.
Thank you.
Mr. Chairman, may I say something?
Sure.
I'm not sure how much you want to get into the Banner Del Webb hospitalization, given that Dr. Thompson did not see the patient there. And I do have more to say, but I can address the hospitalization if you would like, but I would like your guidance first.
Sure. I think we're going to hold off on that just for a minute. I think the question that we should ask is directly to Dr. Thompson himself.
Well, can I ask a question? The doctor on the phone. Doctor, can you hear me?
Yes.
Okay, you can. Good.
Okay. Doctor, I'm a public member of the board, so I'm not a physician. And since you're a relative, but you're also a physician, so you have expertise. So I'd like to see if you can help me pin down. Of course, this is not a malpractice lawsuit against CORE, nor against the hospital, nor against the hospital physicians. Can you just clarify for me where you see the substandard care by Dr. Thompson? Well, let me go back one sec. I think the first question is, are your comments having to do with the period between the surgery in December and the surgery in January, or the surgery and the care starting on January 5th?
Well, first off, typically the post-op appointment is usually 2 weeks, and especially for someone who has had my dad's comorbidities, it shouldn't be longer than 2 weeks. So I do have a problem with Dr. Thompson not seeing my dad right at the start of that new year, because he probably would have caught this right at the initial stages and might have been able to nip this in the bud way before. So that's one of my concerns. Is I agree with the boards recognizing that it was the 3rd of January, 4th of January, and he hadn't even had his post-op visit. Now, next, Dr. Thompson is a core surgeon, just like Dr. Hadi and Brown and all those other surgeons. You know, all the PAs work for them, and all the everyone's dual credentialed at both of those hospitals in Sun City West. So they are, even I think Dr. Nisley is an internist for core, so it's a huge group, I guess. But so he is responsible. Those PAs are his responsibility. They are his agent, responsible for rounding on his post-op complication. So whether he's rounding on that patient or not, he should be aware of what they're doing with his patient. And the fact that nobody is supervising these PAs for a week on a patient who was in the ICU, a patient on pressors, a patient who's super sick, on multiple antibiotics with a heart condition, and you're going to let the PAs do their assessments in a vacuum. Somebody needs to be responsible for this. It's not, the PAs can't just work in a vacuum. And then the surgeons are off scot-free when there's complications because of their malpractice.
Doctor, let me...
The ownership of Dr. Thompson in recognizing, yes, these are my PAs, and they should have been having their notes countersigned. Actually, a doctor should have been rounding on these patients.
Let me be a little more specific, if I could. The surgery on the 5th was performed by Dr. Hadi, and if I understand, the surgery on the 14th was performed by Dr. Brown.
Dr. Brown.
Right. So specifically, where?
Yeah, and I'll tell you why.
Well, let me finish my question, if I could. So yes, and maybe you're getting there, but specifically considering Dr. Hadi performed the first surgery, now we're talking about 2018. Dr. Hadi performed the first surgery and Dr. Brown performed the second surgery. Where do you see substandard care by Dr. Thompson following those two surgeries?
He works with them, and it was his original surgery. Once you get an infection, it's not like tag, you're it. Now Dr. Hadi is in the hot seat if his wound gets reinfected. Let me give you a little bit of information that you probably don't know. But my dad had a cerclage wire put in to bring his patella that was split into 4 pieces all together as one. And it was a beautiful surgery that Dr. Thompson did. It was a perfect closure. However, when that wound gets infected, and there was pus in the hardware, it was a disgustingly virulent wound. What is often standard of care is that hardware is removed because it will just remain infected. There's no way they completely get rid of all the bacteria on this inanimate object in the patient's joint. But Dr. Hadi chose not to do that. I am assuming that Dr. Thompson, as his surrogate, allowed him to do that. It was his original case. If he was aware of it, he may have told Dr. Hadi, you know what, just take the hardware out. This guy's increased risk of reinfection. Let's take away the reinfection risk, and we'll just take out the hardware. But Dr. Hadi chose to leave that in. And when it got reinfected, that's why Dr. Brown operated, because Dr. Hadi knew that I didn't want him to leave that hardware in. And I begged him. I said, please take the hardware out. And he says, it's going to be fine. And it wasn't. So, again, these are all colleagues, but once you do the original surgery, that doctor owns that patient regardless of how many other complications there are.
Okay, that's what I was trying to get at. I assume you're part of a group?
Me?
Yes.
Yes.
Okay.
Yes, I'm an ER doctor. We have 8 full-time doctors at my ER.
So if I understand, your thought is if you see a patient in the ER and release them, and then one of your partners sees the patient the next day, and then there's a negative result after your partner sees them, you're responsible as well.
It really depends on the situation, but if I've missed a dangerous condition that they missed as well, I obviously would be, I was the first doctor they saw, and I missed the condition.
Okay.
So
I just want to...
It would have to be different, and that's a little different than a surgical case where he cut a wound into my dad and put hardware in there. So, he established a very definitive relationship of doing something to him. Yeah, and surgeons are very territorial with their patients.
Okay. And I assure you that if you or a member of your family filed a complaint against Dr. Misley, that will work its way through our board processes as well.
Okay, perfect. I just wanted to know if that was still percolating because I'm not really getting any feedback on any of this until now.
Yeah, we can. If you filed a complaint against him, as much as we can legally say we can give you. Also, just so you'll know, the authority to a PA here in Arizona does not come from the board. It comes from our state legislature and through statute. So
that is responsible for PAs not being supervised.
Well, that's another issue. That the lack of supervision supervision's required, and that does become a board issue. Okay, thank you, Doctor.
No, thank you. Appreciate it.
Any other questions? How about you, Dr. Maedem?
The primary question I have is with a patient with comorbid conditions. Is it typical for you to still have the same basic time frame for follow-up for wound reexamination?
His particular follow-up was at 2 to 3 weeks, secondary to I anticipated more of a prolonged healing period. However, with any discharge of any patient, it's call if needed, and it's documented in the record. And I will tell you, I was taught this a long time ago by one of my trainers. If you look at a person, if you look at their knee, if you look at their hip for 5 seconds, you have the picture, and you're treating the patient appropriately. So if I have any concern for a complication, it's simple. Come to the office. And it may take, because the art of medicine is more than just making our evaluation. I can make the interpretation often in seconds, understand the definitive care almost immediately. But when you talk to patients and their families, that takes minutes or hours, like this particular case. So in that particular instance, if there was any concerns, it's simple. You come to the office. I'll put eyes on it. And unfortunately, with the wound, when it was initially seen, I saw some pictures somewhere, and it didn't look too bad. But what happened is that the skin died. And it necrosed from infection and lack of blood supply between the initial insult. One of my trainers told me this 25 years ago, too. All too often, the initial insult is what determines the overall outcome. You can shatter your tibia, and I can piece it together, and it can look great, and it can just fall apart, because that soft tissue damage would prohibit the healing process. And I think the combination of this poor vascular supply, 20% ejection fracture, sepsis leading to low fusion of a joint from hypotension, the damage to the skin from the initial insult from being on blood thinners, simply compromised the incision. And then that was further compromised by an infection. The outcome kills me. I'm in this not for money, so I'm offended by that comment. I don't know insurance companies, okay? I don't know what I get paid for anything.
Calm down. We got it. Calm down, okay?
Sorry, but that was offensive. The whole point is I'm in this for the right thing. And if any of these students here are in it for different, they should leave the business now. You're in it to take care of people. I was at the hospital late last night taking care of people that are indigent patients. But that's not what it's about. It's about caring for people and doing the right thing. And I try to do the right thing every single day of my life.
Okay.
Mr. Chairman, may I say something, please? I think this will help. The high white count that occurred at the rehab facility was on December 29th. And as been previously stated, the patient didn't go to the emergency department until January 3rd, and that was about 10 p.m. And so he had a high white count, he had hypotension, confusion, and a low sodium. He had 129 on December 29, and then they rechecked the CBC and the CMP on January 3rd, and his white count was around 15,000, and his sodium was 122. At that point, they decided to take him to the emergency department. So there was a period of time there, 5 days actually, where we believe he was probably either septic or had impending sepsis at that time. It's also important to note that a physician did see J.K. at the rehab facility, and she's the one who ordered the lab work twice, and he was also being seen by nurses, and also on the 29th, he had a fever of 100.6. So it's important for the reason in his discharge instructions, Dr. Thompson said follow up in 2 to 3 weeks or sooner if needed. And I respectfully submit that when you have hypotension, a high white count, low sodium, a fever, that's when Dr. Thompson should have been notified that there was a problem here, and he wasn't. And not only that, from the 29th to the 3rd, there was absolutely no treatment whatsoever to address the high white count or the low sodium. And I think that's important. And also, unless you want me to, I'm not going to get into the hospitalization and the facts thereof.
Can I add something to that?
Hang on 1 second. Dr. Erbstrasser, do you have a question from the doctor?
Well, I've got a lot of issues with some things here, particularly with the lack of supervision of PAs over and over, or not having the PAs say, round with the attending, vice versa. So I see this also in primary care and outpatient, right? You have a PA seeing 25 patients without supervision. Mm-hmm. Now, how many of those patients are going to have something real bad? Probably a fair amount. 5% maybe? So the lack of supervision is irresponsible. All right? And that needs to be fixed. The other part that I
Actually,
have...
can I ask Dr. Strasser a question on that supervision, so I understand where you're getting at?
Sure.
If I could. Dr. Strasser, on the lack of supervision, are we talking about generally or in a particular time frame?
Okay, so if you're going to have a PA round on a patient, right, they should be able to assess a wound, determine whether it's infected, determine if the patient has a DVT, right?
Right.
Okay, so they need to be able to do that, and they didn't.
During what period of time are we talking about here?
I don't know. I'll let the ER.
After January 5.
That's the after the second and the third surgery.
Yes.
Okay.
Yes.
All right. Good. Thanks.
Yes.
Appreciate it.
And then, pardon?
Go ahead. Yeah, go ahead.
Okay. And the other doctor that I have, and I know this is a multi-specialty group, and everybody's got their own thing. And this gentleman had 3 surgeons.
Yes.
Okay. And you did the first surgery.
Yes.
And it was, per the ER doc, was done very, very well. But do you feel that there's some obligation? Because I'm sure Dr. Hadi talked to you, and I'm sure these other physicians saying, hey, your patient that you did surgery on is not doing well. And I would think that you would be really caring and want to know what's going on. And in fact, maybe I need to take over the case, because I don't like all these different... this guy had 2 INDs within a week, 10 days. It's twice. So where were you in this whole process? Okay.
So to make a response to your comment about the physician assistants, obviously we take full responsibility for their actions, because ultimately we were responsible for everything that occurs. And that's the job. And so our physician assistants are well trained. We trust our physician assistants. There was one day, I believe, that was mentioned that there was no documentation that the patient was seen, but other than that, he was visited every day within the hospital by a practitioner. And you're right, we have to essentially sign off, if not physically, but verbally, with our PAs in communication about these patients. Okay, so in that regard, we would take full responsibility if there's any fault in care, because again, it's ultimately they're an extension of us. When it comes to the care from my partners, that week, unfortunately, I had worked earlier. It's around the holiday season. And so I had off that first week of January. My partners, all in our group, are board certified, fellowship trained. Every single one. That's our gold standard for our company. And so I trust them. One of those doctors, I did his mom's knee replacement. There is trust in one another. And I really trust both of them are phenomenal surgeons and great people. So as far as participating in the care, I trusted their care. And they did communicate with me. Both Dr. Hadi as well as Dr. Brown, as well as PA Miller. They had communicated with me through pictures during the series of the entire thing, as well as communication. So I did not take over the case, and I trusted their care.
So Mike, can I interject one thing, though, before you go on, is that clearly this was a complicated patient who had comorbidities. And this is a case that went bad. And you have now multiple surgeons involved. I'm going to challenge you and say that clearly if that was my father, I'm going to say your father, I can see where this family is coming from. Because if I had multiple surgeons involved, I'm going to say, what the heck's going on? You say that this is your org system that you use with CORE, but from my experience, being in practice 30 years, is that the surgeon that originally did the surgery follows them all the way through. Clearly, if there's complications, the surgeon is even more involved because most surgeons don't want to touch something that's had a complication. And from a family point of view, how does the family have that confidence? Not unless they say, hey, Dr. Thompson, I don't have confidence in you, you're fired, I'm going to another surgeon, okay? But clearly they had confidence in you, and they didn't know these other physicians, and it seems like the waters became more muddied. Then you have physician assistants who are rounding every day. If it was my father that was in the ICU, and there was a infected joint or prosthesis, whatever sort it was, I want the physician there. I want a PA, you know their training is 2 years, okay? It's not a physician's training, clearly. I don't care how many years experience they can have, they don't have your experience. I would want my father seen by a physician, okay? So my concern here is the fragmentation of the care here. I'm not going to, and with the post-op care, all these things are involved, but in my opinion, you are still responsible. You had the first touch the patient. And so, yes, other surgeons got involved in, and it even got worse and worse and worse, but clearly I can see where the family's coming from. They had the trust and confidence in you, doctor. And so I think this is why they're upset, man. And plus they lost their father. Because they're thinking, what happened, man? What happened? Is this how everybody's treated this way? And I think probably even more so that you have a physician who's an ER doc thinking that everybody's going to go the extra mile. They trusted all of you, thinking that you're going to do it all. Something didn't happen. Okay? And there wasn't that good communication. Okay? So that's where I come from. Go ahead, Dr. Reese.
Doctor, I understand that this patient had comorbidities, multiple system disease, had as you mentioned earlier, an injury, a common injury with a common treatment, the surgery, you simplified it, you wrapped it around and tied it up, and it's all very good. The sense that I'm getting after your testimony is that you have no fault in this. That it was a natural demise, that he was debilitated, that the skin was not healthy, that there was no blood supply, that there wasn't really anything else that I could have done to salvage this. And that's the way you came across to me. Now, you tell me if I'm not right.
Going back, all these patients, you're right. It's if you do surgery, it's like you're marrying the patient, right? They're yours. They're your responsibility, absolutely. Yeah. When it comes to the responsibility of this, every single case, whether good outcome, bad outcome, or indifferent, you have to evaluate how it ends up and the steps that were taken.
So you tell me where your responsibility faltered or didn't falter. I'm getting the feeling that you're trying to tell me I didn't do anything wrong. And I want to know if you actually feel that way or if you feel that you have some responsibility in this. Because
I have substantial empathy for the overall outcome.
Empathy and responsibility are not the same thing.
As far as the surgery was fine. The aftercare, I wish I would have seen him 2 days afterwards.
2 days after what?
Surgery.
Which surgery are you talking about?
My surgery.
Okay.
And then maybe every 2 days after. Well, actually, I did, and he was fine. I'll just say after he was discharged.
Did your office call to see how he was doing?
I don't know if it's documented. We do have where we call the patients and then ask how they're doing after all their surgeries.
Record of it?
I wouldn't have that with me.
Okay. Well, that's immaterial. I'm just trying to get at a certain sentiment that's coming across that you are not taking any responsibility for the outcome. And I want to know if that's true or what.
This was my patient. I assume the responsibility of the patient over their overall outcome. Absolutely.
So
now,
what is it?
But as far as the steps that we're taking,
you're circling the subject. The subject is the overall outcome we all know about. What is it that you did not do right, or what is it that you did right and the outcome occurred? We're just getting a sense that you're not taking responsibility for it.
Obviously, evaluating the wound more frequently, daily, every other day would have been a bigger impact.
Okay.
I'm just, and
So tell us about
that maybe could have changed the overall outcome. All of a sudden, if there's, when I do surgery, I put a bunch of tiny staples and no big staples. And the whole idea is I don't want anything to go into the wound or out of the wound. Just like fish can swim upstream, I feel bacteria. If there's something draining out, something can go in. And so if there's any drainage, that's wrong. And so if I could have seen that earlier, maybe we could have changed this outcome.
May I say something, please?
Go ahead.
Shoot.
Thank you. After Dr. Hadi's surgery on the 5th, the patient began to improve, and on the 7th, he was off of pressors, and then on the 8th, he was transferred from the ICU to telemetry, and he was not even on IV fluids at that particular point. On January 12th, the hospitalist, Dr. Rosen, said, anticipate discharge tomorrow on IV antibiotics. So during this time where the PAs are seeing this patient, we also have the infectious disease doc, Dr. Beirut there. We have critical care medicine, nephrology, internal medicine physicians, all seeing him at the same time. Every day they're seeing this patient. They're not saying we need to do something different in terms of our care. So the PAs are, seeing him, except for January 8th, and there was an issue about the Pico dressing, whether or not that was functioning. Well, I looked at the nurse's notes for January 8th, and it was functioning. So on January 9th it wasn't, and then the PA resealed it, and it was functioning. On the 13th, another PAP in Miller saw the patient, and the wound, they saw the hardware, they removed it. The next day, did an incision and drainage, and placed the wound back. All this is appropriate. I also think, I'm not sure if the board saw our supplemental response that we did. We did a detailed supplemental response in this case. We also had a board-certified surgeon, Dr. Spitzer, out of Cedars-Sinai, review the case, and it was his opinion that Dr. Thompson, Hadi, and Brown met the standard of care in their treatment of this patient. We further believe that the primary problem with the patient was his low ejection fraction, and it's clear in the record that he was in heart failure. And they were giving him Lasix IV almost daily from the 14th to February 1st. And he was having heart problems. They weren't going to do anything about it. They put it in their cardiology notes. And the cardiologists were seeing this patient frequently as well. And I understand that TK is a physician, but he's not a board-certified orthopedic surgeon. In terms of the standard of care, I respectfully ask the board to defer to a board-certified orthopedic surgeon in terms of whether the appropriate standard of care was met. I think it is appropriate to say in your discharge instructions, follow up 2 to 3 weeks, but sooner if needed. Clearly, on the 29th, it was sooner and it was needed, but it wasn't done. And again, there was a physician at the rehab facility who was seeing the patient. And I think, too, in terms of the PAs, I think the physicians who are there treating the patient, who are supervising physicians for the PAs, those are the physicians that you should be looking at. If Dr. Thompson was there at the hospital caring for the patient, then he's one of the supervising physicians. But the physicians who are actually there seeing the patient, they're the supervising physicians at the time. And there's nothing, again, from the 6th to the 12th, the patient's improving. One of the doctors said, discharge tomorrow with IV antibiotics on the 12th. The patient is improving. So that I asked the board to take that into consideration. It's not like he's going downhill during that period of time. He's doing better. His white count's coming down. On the 11th, his white count was 15.7. And again, he's being seen every day by the infectious disease physician who's giving him antibiotics and changing the antibiotics as needed. And so, and I think the other inquiry would be, too, and if I could ask my client, had you been there during his hospitalization, and you've seen what Dr. Hadi and Dr. Brown have done, would you have done anything different?
I would have not done anything different. I would also maybe clarify the pico stressing. I don't know if you guys are familiar with those. Essentially it looks like a white gauze, and it's a negative pressure dressing that has it's battery packed. So what it does is it increases whatever drainage can come out to it. The goal is neovascularization of that area. And with it on, you can't see the incision. And so maybe some of the records reflected that, for the fact that you physically can't see it. You can only see if it's functioning.
And it's very important to point out, too, his initial blood cultures on the 4th showed the staph. But all the subsequent blood cultures were negative, and they did a lot of them. Then when he had the respiratory problem, which I believe is related to his heart, 20% ejection fraction, his device is shocking him. It shocked him during Dr. Hadi's surgery, shocked him like 8 times, from my recollection, during Dr. Brown's surgery. He started getting pulmonary edema. It's on the chest x-rays. The reading radiologist saying he's got pulmonary edema. They're giving him Lasix. They cultured his sputum. They did a thoracentesis. They cultured that fluid. Everything came out negative. There was no growth whatsoever. And which
I need to stop you just a second. Yeah. Please don't let me totally break your train of thought, though. But just for the lay public, the negativity of cultures after initial antibiotic therapy is highly unreliable. So the fact you have a negative blood culture at that time does not mean the infection is gone, but you cannot throw out the infected material on a culture plate because the culture plate itself is contaminated by the same antibiotics.
And
it is important. I'm not saying that's a bad thing, but it's also not reliable.
And regardless, they were still treating him like he did have an infection. The infectious disease physician was still prescribing IV antibiotics for him, so it wasn't like he wasn't being treated. But the treating cardiologist and the treating hospitalist and the critical care medicine doctor, they're all saying that he has heart failure, and they're treating him for heart failure. And we believe that was really the cause of death in this gentleman with a 20% ejection fraction.
Okay. Any other questions, Board?
I do.
I have, because I want to go into executive session soon for legal advice. Go ahead.
Okay. Let me start with Doctor. What is your relationship to CORE?
I am a partner within CORE.
Tell me how CORE operates when a patient comes to core, specifically, let's talk about this case. How did you ultimately end up seeing the patient? Did the patient come to you specifically, or to core?
I'm not sure if I was requested or not, but the general rules, if a person calls in, they were seen in the emergency department, when they call into the call center, we would like them to be seen within 48 hours. And so there were some spots that are usually allocated within the schedules of essentially all the doctors, and somehow that was filled in with my appointment time, or one of my PA's appointment time initially. And so then, because I am then the governing physician over my physician assistant who saw that patient, then I acquired the care of the patient, or JK.
Okay, so he became your patient, and you ultimately, on the 20th, performed the surgery.
Yes.
How do you see your responsibility vis-a-vis a patient that you perform surgery on subsequent to that surgery?
I would be fully responsible.
In this case, you performed surgery on the 20th, and you told him to return when?
It was listed in 2 to 3 weeks. Then I just heard that his follow-up appointment was January the 11th, I believe, as it was scheduled in the office.
Correct.
Mm-hmm. Okay. So you scheduled JK to come back on January 11th with instructions that if there are any issues, see us sooner?
Yes.
And is there anything you've seen subsequently or heard that now tells you that was too long of a period of time, considering everything that's the comorbidities of the patient and any of the circumstances? I know you're not a clairvoyant, you can't tell what's going to happen a month later, but anything you've learned or seen, do you now look at it and say, well, maybe we should have him come back earlier?
Definitely. When you look at the wound complication and knowing that his ejection fraction was low and his blood supply was poor, definitely my practice will change forever.
Okay, and when did you know, again, remind I'm not a doctor, when did you know about the blood supply being low and the wound ejection? When you performed the surgery?
When I performed the surgery and used the tourniquet, that's usually an ominous sign that a person has poor blood supply to the limb. Even though it was documented he had pulses, in general the vascularity is compromised.
So you tell him to come back on the 11th, but issues come up beforehand, and he ends up coming back for surgery on the 5th. Correct?
Yes, I performed the surgery at Banner Boswell Hospital. He was subsequently readmitted to Del Webb Hospital, and that's the evening of the 3rd that he came in. I don't know when the official admission date was, but ultimately had surgery on the 5th.
You were gone out of town what period of time?
The entire week of the 3rd. I anticipate that I think the following Monday, don't hold me to this, is around the 9th.
Okay.
So
he's released on the 20th, and
no, 25th.
Excuse me, his surgery's on the 20th.
Yes.
And then he's released on the 25th. and he's released to a care facility.
Yes.
And the care facility has its own contract physicians, I assume.
Yes.
Okay. So between the 25th and the 3rd, he's in the care facility. And you have to answer yes or no because we have a court reporter who does not pick up head signs. Okay. So he's in the care, JK's in the care facility between the 25th and the 3rd, and their physician's seeing him. What do you see your role in communication care of the patient between the 25th and the 3rd?
That patient would be my responsibility as far as the care of that, the leg and the surgery that I performed.
Okay, you left town around the 3rd.
Yes.
Okay, did you see the patient at all, JK at all, between the 25th and the 3rd?
No.
Did any of your PAs see the patient between the 25th and the 3rd?
No.
Okay. Did you or any of your PAs receive any reports from the care facility between the 25th and the 3rd?
No.
Okay. And help me understand this. If he's your responsibility and he's in the care facility as a result of your surgery, why would you not see or send someone to see or get reports from the care facility?
It's not routine that we would go to a care facility to see the patients. I don't know if I would require privileges at that facility to go there, or but I have not done that routinely.
Yeah, and I'm not trying to argue with you or say it's wrong. I'm just trying to understand what the practice is and what your practice is, and then ultimately I'll hear from my colleagues. But so, what's routine? If your patient goes to the care facility, I guess as if he goes home, you would not normally have any contact with him until he's scheduled to come back.
Correct. And this is the problem they obviously can call.
Okay. So then, I guess, is it someone at the care facility says, hey, there's something wrong here, and JK is sent back to a hospital. Is that right?
Yes.
Okay. And then a determination is made an additional procedure is necessary.
Yes.
Okay. When did you next, after the surgery and JK went to the care facility, when did you next have contact with his case?
I cannot quote a specific date, but I would imagine it would be towards the end of the first week of January.
Well, okay, so it was not, what I was getting at is, did you know he came back to the hospital?
I did not.
But Dr. Hardy is your partner, and he ended up performing a procedure. So someone at CORE got notice that JK's in the hospital.
Yes.
Yeah, how did that work?
They would call the answering service, and then that would be filtered to whoever was on call to cover that hospital that night.
Okay, they meaning?
So our main operator would then call out to whoever's on call at that facility, covering the facility.
No, I mean, let me go back. Who would contact CORE to start with?
Either the emergency room or the family or the patient.
Okay.
But when a person comes into the emergency room, the emergency department will call our facility.
Okay, they know, even though it's a different hospital, they know you perform surgery.
They would not know that.
So why would they call your facility?
So if the patient came in, JK came in, and they said, Dr. Thompson from CORE performed the surgery, then the emergency room would often call our answering service and then get whoever is on call for that hospital. But the person that's accepting that phone call would not know that that necessarily was my patient. Even though sometimes they can put on the page, please call a patient of Dr. X's. So even though it may not be my patient, it may be on the page saying that it was a patient of one of my partners.
Well, maybe this is, I think, collateral, but if the hospital calls CORE, CORE is going to know, the person at CORE is going to know or should know that it's your patient. All you need to do is go on a computer and find out JK, date of birth, so-and-so, this is Dr. Thompson's patient. Now, maybe they didn't look, but they should know.
Yeah, a PA Zastro and Dr. Hadi, they would know that JK was a patient of mine.
Yeah, but even before Dr. Hadi got contacted, as soon as the call comes into CORE, CORE should know it's your patient. Just go on a computer and find out whose patient it is.
Yes. It depends on the answering service receiving the call. The answering service themselves may not be privy to that information.
Okay. So it goes into CORE, and you're gone. Dr. Hadi performs the surgery. Dr. Brown performs the follow-up surgery. You get back when?
I believe it's around the 9th of January.
Okay. When do you find out that JK is back in the hospital and underwent the procedures?
I couldn't tell you that exact date. I know that PA Miller most often works underneath me, and when Dr. Brown, prior to undergoing that procedure, I remember getting a picture from him, but I'd also gotten one before. So I'm assuming it's maybe even a few days before I got back.
Okay, well, you're back before the second subsequent procedure.
Yes.
Did you know there was going to be a second subsequent procedure?
I did not know that.
Okay. When I say back, you're back in town. Were you back at work?
I was back at work, yes.
Okay. If he's your patient and you're back at work, how do you not know there's a second procedure? How does it all work?
Right. At that time, Dr. Hadi had taken over that case, taking care of his wound.
Okay, so Dr. Hadi would have known there's a second procedure.
Yes. If there was a decline in the status of the wound, yes.
Then let me go back to the question we talked about a little bit ago. Now you're back. There's a second procedure on the 14th. When do you next see JK?
I never did.
Okay. Now let me then go back to my other question, is if he's your patient, you're back, he's in the hospital, how do you not see him?
He was at another hospital that I normally do not go to, and my partners were taking care of him and then just simply keeping me updated.
Okay. Normally meaning you just don't go there, or you don't have privileges there?
I do have privileges there.
Okay. So within your system, is it, well, your partners go there, so they're going to go ahead and take the care from you because they're there?
That's, yes. Much like if their patients had come to my facility, I would take care of that patient.
Now, within CORE, are doctors assigned to facilities?
Yes, we cover a main facility. And then sometimes we'll cover on weekends, we'll cover 2 facilities.
Okay, right. Did, to your knowledge, did any PAs see JK subsequent to the second surgery? Well, let me put the question this way. Did any PAs you supervise see JK subsequent to the second? By second surgery, I mean the second subsequent surgery.
Yes, PA Miller more commonly works with me.
Okay. And he saw JK?
She did, yes.
She did. How many times do you know?
I'm uncertain.
Did you get reports back from her? Or did they go to Dr. Hardy or Brown?
She was working with Dr. Brown at that point on the weekend that was undergoing, but she would keep in contact with me just verbally.
May I interrupt just for a second? I can tell you when.
Okay, please.
P.A. Miller saw the patient with Dr. Brown on January 14th, and Dr. Brown saw the patient on the 14th, the 15th, 19th, and the 31st. Another PA, Bradford Tenney, saw the patient on the 21st, and then the infectious disease doctor was seeing the patient regularly as well.
And she also saw him on the 13th.
So,
Yes, and she also, P.A. Miller also saw the patient on the 13th.
Dr. Thompson, between the 14th and into between the 14th and the 2nd of February, you didn't see JK at all?
No.
And the people your attorney just mentioned did see him?
Yes.
Between the 2nd and the 15th of February, did you see JK at all?
No.
Did you know what was going on with JK during that 13-day period?
Not at that period, no.
Do you know if Dr. Hardy or Dr. Brown knew what was going on?
I can't answer that.
Do you know if anyone from CORE knew what was going on?
And I'm sorry, at what time?
Between the 2nd and 13th, 2nd and the 15th of February.
Dr. Hardy did perform surgery on January 5. And
I know, between February 2nd and February 15th.
No, he was already discharged at that time.
I know he was discharged. That's not my question. Okay. Yeah, I understand that. But let me go back. Between the 2nd of February, when he was discharged from Banner, which is Del Webb, right?
Yes.
As we used to call it. And the 15th, you did not have any contact with JK or the family?
No.
Do you know if Ms. Miller had any contact with JK or the family?
I don't believe so.
Do you know if anyone in CORE had contact with JK or the facility or the family?
I don't know.
So, if I understand right, from the time you left on vacation, you really had you personally now, had no contact with JK or his family.
True. And
between the time you left on vacation, and certainly no one's faulting you've gone on vacation, your PA, Ms. Miller, had no contact with either JK or the family.
She had contact on the 13th, right, the 14th, and the 15th.
Yeah, those one times at the hospital. So in essence, the care of JK was transferred from you to, if not on paper, but in reality, was transferred from you to other doctors in CORE.
Yes.
Okay, and is that, even though you performed the initial surgery, is that the normal procedure, or did this procedure go awry of what your normal procedure would be?
If I had a patient that was readmitted to another facility, say for observation, and was treated, I would hopefully see that patient back. Or if they had a subsequent surgery, if Dr. Hadi had done the initial surgery, I would hope to see that patient back and have a continuum of care.
Yeah.
But you're right, this one didn't necessarily follow that standard.
If you're the treating physician, you leave and you come back, wouldn't you think one of the first things you do is check on your patients? I manage a group of attorneys, and if I go away for a week or two and I come back, first thing I want to know is what they're doing and what happened. If you go off and come back, wouldn't one of the first things you do is, okay, what's going on with my patients? Or is that not the way things are done?
Well, I absolutely taking care of my patients, and as you know, before you leave for vacation, you have a bunch of influx of patients, the ones that you worry about or need to be seen. Then when you come back, you're also inundated with a large population of patients greater than normal, just because that little void you had in continuum of patient care. And so, absolutely, and I was updated by, my staff members intermittently on the care of the case.
But you said you didn't know anything was going on with J.K.
Not until probably the end of the first week of January. I did not know he was readmitted.
Okay, so you found out he was readmitted.
Yes, and because Dr. Hadi, I had seen a picture of his skin that unfortunately it had a little bit of drainage, didn't look that bad, and I was informed that he had taken back for a washout.
Okay. And when's the next time then you were informed of something by anyone?
P.A. Miller, she informed me that he was still in the hospital and that unfortunately the wound had dramatically.
When was that?
That was on the 13th, 14th, and 15th.
After the 13th, when's the next time you were informed about J.K. by anyone?
I cannot recall any specific dates. I'm sorry.
After the 13th, when's the next time you reached out to anyone to find out what was going on with him? Or did you reach out to anyone?
I don't recall the specific events of time, but I knew that the patient was going to be discharged from the hospital.
And that was February 2nd, roughly?
Yes.
Okay. So somehow you found out about that?
Yes.
Okay.
Through Dr. Werner and Hadi and Dr. Brown.
Dr. Werner is another one of your partners?
Yes.
Okay. Thank you for the time, Mr. Chairman.
Any other questions before I make a motion? Do you have a question, Dr. Strasser?
I'll wait.
Okay. I was going to make a motion to go into executive session for legal advice. Can I have a second? Second. All in favor, signify by saying aye. We'll be right back. back in session after obtaining legal advice. Did you want to ask a question, or do you want to go first? Did you want to go first?
I'm okay either way.
Please go ahead.
Mr. Chairman and members of the board, listening to the board's questions, it sounds like this is almost like a case of abandonment, which is not the case at all. The patient had 2 board-certified orthopedic surgeons plus physician assistants caring for him. As far as I know, there is no statutory or rule violation for an orthopedic surgeon to say to his partners who are well qualified, I would like you to care for my patient. And so from that standpoint, I don't think that there's any kind of disciplinary matter here.
But isn't there a statutory violation for not following a patient? Doesn't that compromise the patient's health and safety if you don't follow if you are responsible, and if you admit you're responsible, and this is not arguing with you, but a question. Sure. Kind of like oral argument, I guess. Isn't there a responsibility, the doctor, if you admit the patient's your responsibility, don't you then therefore have that responsibility to follow up on the patient?
My point would be, in terms of like an abandonment issue, if there wasn't another orthopedic surgeon caring for him that's qualified, then I would take your point. But people are allowed to go on vacation and allowed to,
Sure. But afterward.
Well, then the issue is whether or not he's being properly cared for by a board-certified orthopedic surgeon, and as Dr. Thompson said, whether he would have done anything different from what Dr. Hottie or Dr. Brown did, and he said no. So even though had he shown up, he would have done the same thing that they did. The other thing I would like to bring up too is at the rehab facility, the patient did develop a decubitus ulcer in his right buttocks, which was present then and then all the way through his hospitalization at Del Webb. And I bring that up just to say that that is a potential source for the leukocytosis besides the knee.
But Mr. Landa, I don't think that's really a statutory violation. Although I'm not 100% thrilled with the group practice model, I absolutely, of course, understand why it's necessary.
That's why I'm asking these questions, to get other opinions.
Yeah, the best I can tell, the doctor did find surgery to begin with at an unfortunate complication, which does happen, and the PAs and everybody else was supervised and was taken care of, and the PAs were supervised by other physicians at the time, which was with an appropriate group practice.
And I point out that this proceeding here is not a lawsuit against CORE, and it's not a lawsuit against any particular doctor. It's a determination as to whether this doctor followed the statutory requirements in the practice and in the standard of care. Now, clearly, the CORE model seems to be at risk. Personal thought, just listening. What complicates things if the doctor is a partner of CORE, does he bear any responsibility? And maybe he does in a malpractice suit, but does he in a proceeding determination whether or not he violated any statutes? And they're two different things.
Yeah, and just quickly, I think from the medical malpractice standpoint is whether or not Dr. Thompson acted as a reasonable and prudent orthopedic surgeon, and the medical consultant concedes that Dr. Thompson met the standard of care in his repair of the knee. And is it reasonable and prudent for an orthopedic surgeon to let his partners who are qualified to care for this patient? And the answer to that is yes. And I think the other point is, and this didn't come out exactly, but I think it should be said. Had Dr. Thompson been called on December 29th and told about the fever, the white count, low sodium, hypotension, he would have wanted to have seen the patient. And I don't think any of the board members would say if they had a patient like that, they wouldn't have wanted to be called about that, and that it was reasonable to rely upon the nurses at the rehab facility and the doctor there to call him, or at least or send the patient to the emergency department 5 days sooner than they did, so he could receive treatment. So I respectfully ask the...
Go ahead,
Yeah,
Dr.
but
Rosati.
you know how you could do that? You could have the patient come into the office instead of having them come back on January 11th. All right, this is a high-risk patient in a high-risk environment with a big surgery for potential for wound infection. So, of course, he would love to have been called, but what if he had the patient come in 3 days after being discharged? Okay, so that's, don't always rely on other people going to call you and make you aware of those circumstances, because they're not. Well, you have to be responsible. No, he's a high-risk patient. You said it yourself during surgery. He is. He had ejection fraction of what, 25-30%. High risk. Okay? So automatically that should say this person needs better, closer follow-up. That's all. And you may have caught in this, and who knows what would have happened.
Yeah.
So don't rely on the other people to expect a call. Well, the nurses, okay?
And in terms of the plan, that was the reason why one of the reasons why he was discharged to a rehab facility where he could be treated and monitored closely, as opposed to sending him home.
He was evaluated there. He did have labs drawn. He was seen at that facility also. I agree.
So
that was you're responsible.
And I think the doctor, you stated too that you thought that the patient, looking back, you would have had him come in earlier, or looking at now cases moving forward, you would have him come back in 2 days.
Yeah, I mean, looking back, and how could this be corrected? Obviously, first of all, I wish I didn't do the surgery. Even though there was clear indication radiographically, my eye test was concerning, and I just wish JK was still here, and we weren't here. But that's hindsight. Like you said, I don't have a crystal ball. I've done so many of these surgeries, and this has never happened. But it's my responsibility, you're right, to care for these patients. And if I would change it in hindsight, I either just simply won't do the surgery and have them seek another consultation if they're adamant about it, or seek closer follow-up.
Not do the surgery because we ended up here, or not do the surgery because there might be too much of a risk?
Risk benefits. Everything's about risk benefits. And so and it's tough to categorize it. It's easier to do it in something that's more commonplace, like joint arthroplasty, where you can say these are risk factors, therefore you can really categorize it. And unfortunately, it's more the practice of being a surgeon and saying, based on labs, vascularity, et cetera, whether or not we believe the outcome is going to be good. So in hindsight, obviously I wish it wouldn't have gone through.
Yeah, I'd like to hear if there are any closing comments. We've heard a lot from your counsel, from Dr. K or CW. If there's anything else you'd like to say, give you all a final opportunity.
I know my brother wanted to say a few things.
Yeah, I thought maybe you would.
And the only thing I wanted to say is perhaps we could show the pictures that I showed you to Dr. Thompson.
Dr. K, you still on the phone?
Yes, I am. I had a couple comments, if you would allow me.
Sure. Is that okay, Mr.
Yes,
Chairman?
absolutely.
Please go ahead, sir.
Now?
Yes, please.
Thank you. Okay, a couple things. I appreciate Dr. Thompson mentioning that having a board-certified orthopedic surgeon, caring for a board-certified orthopedic surgeon's procedural complication is the gold standard. I completely agree. Where I disagree is the PAs following the post-op evaluations without any physician oversight or supervision. I would probably call that a stainless steel standard, not the gold standard, or maybe a regular steel that rusts. Secondly, I talked to Dr. Hadi the day he was doing that first surgery, and I asked why Dr. Thompson wasn't there doing it, and he told me he wasn't available, but that he made Dr. Thompson aware. So Dr. Hadi told me on the 5th of January, that Dr. Thompson was aware of his post-op complication. One of your board members, he said a great comment. He said, if my family member or me is in the ICU after an infected knee joint, I want the physician there rounding on me. And I completely agree. And even if the PAs are there and they're getting some supervision, that's kind of this day and age, but complete lack of supervision, nobody wants that. Dr. Thompson, I appreciate that you finally, after some questions, took 100% responsibility for this post-op complication. I don't think the board is punishing you for having a post-op complication. We understand that they happen. So I don't want you to think that there's any issue with having a complication. It's what happened after the complication. That's the problem. One of your, I don't know if that's your attorney or someone speaking for you, said, my dad had all these complications, heart failure, he was getting Lasix every day. We couldn't do anything about that. My dad got Lasix every day when he was home, and he was functioning fine. You mentioned he had a white count of 15.7, it was coming down. If anybody knows a white count, that's not normal. So just realize that there was no look for the source. Nobody was looking for the source. You had mentioned, Dr. Thompson, that the Pico drain, some simple device, battery operated, and even a caveman can use it. Do the physicians rounding on your patients, the non-ortho physicians, have autonomy to remove the Pico drain if they're concerned about infection? If the patient says they have worsening pain, or do they have to go through you or the PA to get authorization to take off the Pico drain to look, see if there's an eschar or protruding hardware, as in the case with my dad? And finally, I don't know whose purview it is, but the rehab facility where my dad was from the 25th to the 2nd or 3rd of January, for them to know he has a fever and an elevated white count. And I would love to know if maybe CORE was notified and that fell on deaf ears over the holiday period, or maybe they never did notify CORE. But it would be interesting to know if they were asked if they actually did indeed try to contact CORE and were unable to. Thank you.
Okay, thank you, sir.
Okay, first thing, if I need a motion, I'll make one. I'm going to ask that, and I'm not saying there's responsibility or blame or substandard care, but it needs to have a look, that we refer the case of Dr. Hadi and Dr. Brown to the medical board for review, and also refer the applicable PAs to them.
Hadi is a DO, is that correct?
Is Hadi a DO?
No, and actually the board already has those cases.
Okay.
All right, and if the board does not, refer the applicable PAs to the medical board as well for review. As to this particular case, and I'm not here to assign blame to others or even determine if there are any blame to others, but certainly there were issues raised here that need to be reviewed. But as far as Dr. Thompson is concerned, and listening to my colleagues as to what the standard of care is and what was done from the surgeries and on, I'm going to move for a letter of concern for not requesting that JK be looked at in a shorter period of time than 3 weeks subsequent to surgery.
I'll second that. And so as the motion is from Mr. Landau, the second is from me. Before we vote, is there any discussion?
I'm sorry to take this at an inappropriate time, but I just wanted to say, first of all, sorry for your loss, and thank you for your father's service.
Absolutely.
Yeah, it struck me that he was a fighter pilot, and if you're a fighter pilot, you're going through more than anyone else in their life can go through from the people I know who are fighter pilots.
That was appropriate.
Yeah.
Any discussion before we vote? Can I have a roll call, please?
Yes. Dr. Reese?
Yes.
Dr. Madem?
Yes.
Dr. Erbstrasser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. Thank you all for being here, and thank you for bringing your photos. Again, sorry for your loss.
Thank you very much.
Could we have those photos returned to us as part of the case file?
Yeah.
Yeah. Yeah, you may.
And Doctor, thank you so much. It's Dr. Cunningham again. You heard the letter of concern, and this concludes the case. Thank you for being here and also being on the phone call. Sorry for your
Let me
loss.
say one more thing.
The case is done. Thank you very much, sir. Thank you.
Okay, appreciate it.
Thank you.
Thank you.
Thank you. I'm going to take a 5-minute break. Just a second. Let's just do it all together. What you guys have to leave for exams? Oh, okay. I get it. I get it.
Exams get in the way of doing other things.
This has been very informative, very
It's been a lot more.
Kevin, nice to meet you as well.
We get paid so much for doing it. All right, you guys. Tell us, what did you guys learn today so far this morning? I know you didn't see some other cases are coming down this afternoon, but what did you guys learn so far this morning? Document. What else, man? Anything else?
It's a little concerning that it's solely focused on what standard of care is rather than what the physician should do from that's just something they should do for empathy out of the patient.
Yeah. You can see why we kind of struggle.
Yeah.
Like why we struggle.
Isn't osteopathic medical education supposed to comment on that or cover that or bring that up more than, say, allopathic medical education?
I think that's what we're known for.
Yeah.
Take care of the patient. Take care of them appropriately. Globally take care of them.
Just remember one thing, empathy won't pass this exam.
Yeah.
So he's the answer on the board question.
There's more cases coming this afternoon, but we worry about, substance abuse and those things too, and so, we might have some cases this afternoon that might deal with some of those things, but clearly we want to talk to you about substance abuse. And if you have any friends, yourself, if you've got a problem, take care of it now. I'm going to just tell you. It might cost you a year, out of school, but take care of that, because if you come before the board, it's more difficult. It's a very difficult process. Dr. Prosh, she can tell you about the program that we have for the confidentiality program.
If I could expand on that.
Go ahead.
A year out of school saves you a lifetime of work that you would not have, and all these people you could impact if you were working. So if you or your friend needs to take a year, take a year. We got a long time to go.
It'll catch up with you, I'm going to tell you. It'll catch up with you.
Sorry, Dr. Brown.
No, go ahead, Dr. Brown.
No, I was just going to say that we, in Arizona, we have a confidential physicians program with our board. The medical board has one as well, but we have one in which if a physician reports to us, self-reports that they have a problem with drugs or alcohol or any other thing that would limit them from practicing, we will help them get help. We will send them to the appropriate evaluation and treatment facilities, and then put them on a confidential probation for whatever period of time is recommended by the evaluator, and monitor them either ourselves or with a monitoring company, all done completely confidentially so that the physician can become healthy and able to practice without concern about their addiction. And so it's not reported to the data bank. It's not reported to even the board. We know about it, but the board members, and it's not ever, unless there's a problem in that the physician has a relapse. So it's a really good program. Not all states have it. We're really lucky to have it. So if you know of anyone that is in that kind of a position, you should encourage them to self-report. And I think in your situation, like they were saying, it's so important to get treatment early before there's been any kind of patient harm or legal harm to yourself.
Jared, it's your turn. The records. We got one this afternoon. Is it this afternoon, I think? Oh, no, not this afternoon. I reviewed a case early this morning. Anyway.
There's one other thing I wanted to mention about what did you learn. I think one other thing that came out of this morning is communication. It is really important that you communicate with patients and you communicate with the patients
and the family.
Family, yeah. It's really
here
important.
We had a family, medical family. You kind of think we go out and even a little bit further, take care of our own colleagues.
Yeah, and that is, and if you get into a group, be careful because these groups are businesses, and practice of medicine, practice of law, same thing, is a business. And you got to be real careful. Doctors, lawyers get in trouble, not so much for the practice of medicine and practice of the law, but it's the practice of business. So you got to really watch that and be careful, and you got to make sure you do what's right as far as your practice and your patients and the public safety. You're starting out your careers right now, and you're going to be practicing for many, many years to come. And you're going to be applying for licenses here and maybe other states. Because of the Interstate Medical License Compact, which the Federation of State Medical Boards had a big part in starting and is now in some 30 states, it makes it easy to go from state to state. But you're still going to have to fill out applications. You have to fill out applications for residency, for fellowships, for licenses. And they're going to ask you to go back to square one. And you're going to have to go and tell them where you went to medical school and what hospitals you went and what clinics you worked in and what fellowships. And by the time you get to filling out an application, some of the hospitals may not be in existence anymore. And they're going to ask for your records. And you're going to try to get the records. The Federation of State Medical Boards just made an agreement with a hospital in Philadelphia that was sold and was closing to take over all its records. So,
is that Hahnemann?
Yeah, Hahnemann, which is what, University of Pennsylvania, I think, is out of business. And if you're a resident there, and 5 years from now someone asks for your records, where are they? What I'm getting at is, it is really smart to sign up with a credentialing service. Now, I'm not here to advertise one. It's one I know, but there may be others out there I don't know. The Federation of State Medical Boards provides, because there's a need for it, the Federation Credentialing Verification Service, FCVS. If you go to the Federation website, FSMB, Federation of State Medical Boards.org, and you'll find the FCVS. It's easy to sign up. It's relatively cheap. You send your information, your records over. It's a primary source of verification, and you can get information back in minutes. A requesting board can get information back in minutes about it. It is going to save you trouble. I get calls, and I head a group at the Supreme Court that is our government affairs group. So I get all the constituent complaints and all the people calling in. And one of them I get is, it's taking me so long to get a bar license, to get a law license. And the problem is they started the background check late, and they have to go back and find records from New York or somewhere else, and it takes some time. So I really suggest you look at that and sign up for a verification service. It's going to make your life a lot easier going down the road.
Yeah, I have a case I was doing early this morning before coming here. And
well, you're working early. I'm impressed.
But anyway, that's just me. But anyway, the physician's going to have to come before the board because they can't verify their internship because of the hospital's closed. So now they got to come before us and get a waiver then. Wow. So paying for them, paying for you guys. So do what he said, learn now too. The other thing is when you're filling out your application for each state, you fill it out. Oh, don't let your girlfriend, boyfriend, wife, or whoever, the secretary, the office manager, because if you fill it, it's filled out wrong. Remember, you sign it, and it's a legal document. And so when you come before us and it's filled out wrong, or you didn't disclose something, we're going to say, what's going on? You know.
We've had that recently.
Yeah, we have.
Yeah.
The only other thing I want to tell you too, if you drink alcohol, what do you guys do? You call who? Uber, man. Let me say, because I'm going to tell you, and if you've even had a DUI when you were younger, in college or anything like that, you've got to disclose it, okay? Don't take that risk. I have one drink, I have Uber, I have somebody else drive. I'm not a big drinker, so I don't have to worry about it. But anyway, I'm just saying, please call Uber, okay? Do all those things. Anything else?
Well, who here thinks medical school is stressful? who thinks it'll get less stressful when you're done?
It's not. Just beginning. Just beginning.
Yeah, so it's easy to break yourselves. You have a long way ahead of you. Stress is terrible for your relationships. It's terrible for your life. It's terrible for your work. So just keep in mind that it's set up for disaster, but it's something that you could do something about. It's all about perspective. Find joy in what you do, not misery in the problems with what we have to do, because they'll be there. But just remember, every day you get to see somebody and make a difference, and that is worth the stresses and the, can I say crap?
It's a nice way to say it.
Yeah, exactly. So just remember, find happiness in what you do. You have this opportunity here. Make the best of this opportunity for a long time to come.
Gary, you got anything?
That's great.
All well said.
That's great advice.
And I didn't explain to you guys, we're all appointed by the governor. We have Justin, who's our executive director. Jean Galvin, I don't know what to do without her. She's our attorney general. You can tell she keeps me in line. And then Dr. Praw, I'm going to tell you, she's our primary investigator. We got John over there too, investigator. We have staff as well. Dr. Reese, he's our psychiatrist. Like I said, he's my senior statesman. Jerry Landau, he's the judge. He wrote all the DUIs laws in this state, okay? Invaluable for us, okay? Dr. Madam, ER doc, and also Dr. Dresser, primary care, family practice, just like I am. Nate is suffering with me every day. Any questions you got, Nate? Any questions you guys got? Any other questions you guys have? Go ahead.
So when it comes to moving forward from a case review to investigative hearing, is there anything specifically the board looks for to make that motion? I know it's a bit broad because there's lots of different cases.
I think each case stands on its own, but the reason we kind of like having the complaint there because maybe the investigator saw there were no problems at all, and they might show light on something that maybe that didn't come up in the, with the investigators. So, and I think then there's cases that we go immediately say, we have a reviewing process that will go immediately to investigative hearing. So it kind of just tips the scale one way or the other, or maybe it's just we get more information and we'll say, you know what, I don't think this needs to move forward. So that's the reason we have case review.
If there's a chance that we're going to find some sort of a deviation from the standard of care, it has to be through investigative hearing. That's the only, that's the initial mechanism. It can't be through case review. So there's a question about the conduct. We're going to need to move it through.
Any questions, sir?
Question here.
Sure. I was just curious, how much credence is the outside medical consultant given, that report given, here? Is it just viewed as like another source of information, or is it viewed as like this is the probable truth until we learn otherwise? How is it viewed?
Each case, like I said, stands on its own. We take that, what we call our consultant. He does hold a lot of weight, he or she, or whoever that is. But ultimately, the board makes its own decision whether we take their consultant's report or not. We have rejected other consultants' reports in the past and say that it is not a good, and we feel that it was not a good report.
Anyone have a serve on jury?
Yeah.
Here? You will eventually. If you have a serve on a jury, you'll get a jury instruction from the judge that says you are the judge of the credibility of the experts or credibility of the witnesses, and you're able to. You can consider the experts' background and expertise, training, and education, but ultimately you give it the weight. And as Dr. Cunningham said, well, I'll listen to it, and along with all the other testimony, and then I'll give it the weight I think it's accorded, and the fact that the person's a board certified, whatever, that's a factor I'm going to consider, and how she writes the report, and how it plays in with the rest of the testimony and the rest of the reports, and that's about the weight, how much weight I'll give it.
Dr. Reese? Today was a bit of a unique day. We didn't see a whole lot of cases today. But it is a very instructive day because there are two cases here that you should really absorb. They both involve communication with the family. And remember these cases because you need to stay in touch with that family. That girl, that suicidal patient, that doctor should have stayed in touch with that family, should have gotten more information from that family. The last case, that doctor really neglected to stay in touch with the family. Call the family. How's your dad doing? I'm really interested. Even if you're busy, you can project an image of interest, and it goes a long way.
I think this would have been a lot different with this last case if you would have, especially talked to the son, had the courtesy.
Don't get into a routine. Yeah, there is a routine in any job we do, but if you get into a routine, you get into a rut. And that's where I think you run into.
Gene, you were going to say something about consultants.
Just at the outside medical consultant report with the case with the psychiatrist, our outside medical consultant found several deviations from the standard of care, but the board ended up not finding. So that is where it's
Right, exactly. How many of you guys go? Oh, go ahead, Nate.
So
you better ask a question.
So what was? Is he going to come back before the board, the last doctor?
No, it's done.
Is it all done? What level of discipline was that? What is the
So, letter of concern, it is a non-disciplinary letter of concern. Administrative warning is disciplinary. We have decree of censure, which is disciplinary, suspension, and also revocation.
And probation.
And probation. And after that, then there's dismissal. Okay? So he got off easy. I'm going to just tell you he did.
Yeah, it shows, it's on his record that shows, that doesn't go out to the National Data Bank, that shows the board had a concern about a person, a particular part of his conduct in dealing with the case, but not enough to rise to a statutory violation.
Can the patient look that up and see the letter of concern?
No, they can do that in contact with board. But it won't be on the board website. No. They used to be. And then the governor changed that.
Yeah, that's a legislative decision.
Yeah, so the governor changed that.
Did you have a question?
That was my question. About the letter of concern. I just didn't know what that was.
Any other questions you guys got? Go ahead.
So it sounds like you guys have this great confidentiality for substance abuse issues,
Mhm.
but is there a similar level of confidentiality for maybe mental health issues, or I mean, since
That's a good,
burnout is
good
something-
question. Good question. Good question. We've kind of changed that question on our application now too. So we do have something that's kind of similar. You want to say what that is, Dr. Praw? I don't know. It's not to the degree of having a like substance dependence, but I think there's also then the confidentiality. It's a question if it's something that's happened recently or something that's in the past.
Yeah, I mean, if there were a similar thing, if there was some report about something, then we would probably follow the same kind of guidelines.
So yeah, if you have a question, I want to just tell you to disclose when we're there. It's better to disclose and talk to our executive director than to not disclose, okay?
And if you don't mind the Monty Python quote, who are you who is so wise in the ways of medicine? This is one of our hottest subjects, which is why we bring up these things such as the stresses of school, the stresses of the job, stresses of life. And this is something that is one of the biggest nails in our coffin in medical care, is breaking the person providing the medical care. So this is something we have brought up at the Federation of State Medical Boards, and it's going to continue to move forward in a positive direction if we have anything to do with it, because we want to make sure that the physicians feel safe in saying, hey, I have a problem, and I'd like to still do my job. What can I do?
Mental health is evolving at a rapid pace. How we deal with mental health, both in the medical field and in the legal field, and in the treatment field, it's really evolving fairly quickly.
Who's going into primary care, family practice? Yay! You need more. Yeah, good. Great job. Orthopedics after the last case. Anesthesiology.
Lone Ranger over there.
Okay, good. ER? Okay. Psychiatry?
Keep your options open.
There you go. There you go, Dr. Reese. You got another one coming down the road. All right. Any other internal medicine? Okay, good. Pediatrics?
You're raising your hand for everything.
Sounds good. Great. Anything else I missed? Anything else I missed? OB-GYN? Radiology, OB-GYN? Good.
There was an article in the Arizona Republic today about rural medicine. You might may or may not be interested, but you might go ahead. It was a relatively long article under Republic standards, I guess, but about rural medicine, the lack of doctors in rural areas and why. So it was a good article. You might take a look at it.
Yeah. Thank you guys for coming.
Thank you.
See you Monday, Dave.
Bright and early.
All right, take care, you guys.
Bright and early.
Good luck on your test,
I'm going to have to
okay?
disclose because it's the only thing to
If you guys,
explain to 5-year
Midwestern
absence.
people, if you want to
one
continue to
medical
come this
school
afternoon,
and
you're more than
Be
welcome
sure
to.
to sign out on the
Okay?
sheet, please. For your
Like,
school.
would it
We're going to
technically
break
be
for
legal not
lunch.
to disclose
I think.
that, like, if somebody who's 17 had your sobriety, or...
Yeah, it's not on the same line.
in session. All right, so we're going to start with number 7, DO-19-0145A, and this is for consideration and action and compliance of board orders. And DO-19-005A, Anthony Christopher Posen, DO, license number 3684. Dr. Posen, please come forward there. Do you want to go into executive session right away, or do you want to?
Yeah, might as well.
We don't.
Start.
Huh?
We can start and then go in. Yeah, introduce them and then go.
Go ahead.
Do you? Okay.
Dr. Posen, do you want to? What's going on with it? What's going on with Dr. Posen?
This is Jean. Yeah.
It's a violation of board order. Just introduce and then go into executive session.
I just wanted to make sure I wasn't
Okay.
overstepping
All
the
right.
bounds.
So I was just say that I know there's been a.
Oh, so yes, Dr.
There's an
Posen.
issue.
Dr. Posen actually has been on probation with us since May 23rd, 2019, and he was originally placed on probation for 2 years. He did have a relapse on July 4th, 2019, when he consumed alcohol. He was selected for a urine drug screen the next day, July 5th, and he did contact the board to notify them that there would be a positive result, and we got one. During the discussion about the positive result, we talked about the fact that we would probably be wanting him to go into treatment. And we talked about places, and Calvary was one of the places that I mentioned. And he took it upon himself to call them and check in for treatment to Calvary on his own on July 10th. He was cared for there and did well according to the treatment people. And then he then entered an intensive outpatient program afterwards, or at the very end, and then he entered a PHP, which is a completely outpatient program. He now is monitoring with us, with our board, and he has he's been compliant.
Okay. And that was not a board order for him to go to Calvary, is that correct?
That's correct.
Okay. So we have no discipline that we have done since this violation of the board order, is that correct?
That's correct.
All right. Doctor, how are you doing?
I'm great. How are you?
All right. Good. How are things going with you, with your recovery and so forth? Is that going to go into executive session for this, or no?
It's not a confidential order.
Okay. So how are things going?
Things are going well for me. I'm 70 days, at least, in recovery. When we met back in May, Dr. Reese had outright told me that I have a substance abuse issue, and I was in complete denial.
Oh.
And when I could not refrain from consuming on the 4th, I realized that I had a true problem, so I checked myself in. And I'm now in a 12-step program. I have a sponsor. I go to 4 meetings at least a week. I'm still in therapy 3 days a week. And I've really come a long way since the summer. So.
Are you practicing now?
I'm not practicing. I've been basically off since July 17th.
Were you terminated?
I was terminated.
After what happened? Because of your relapse?
The group found out that I had to go into a rehab program. I told them I was going to a rehab for 30 days, and they found a little glitch in the contract, and they terminated my contract.
Okay.
So since then, I've lined up another position with a group in Glendale.
Okay. When are you starting with them?
October 1st.
October 1st. How many hours are you going to be working with them?
I'm only doing 5 half days a week right now.
So how many hours is that?
6.
6 hours. Okay.
Give or take. 8 to 1.
Okay. 6.
25 hours a week.
Yeah, 25 hours a week. Okay. Questions, Dr. Reese?
Doctor, you look a little dour, downcast. Do you feel that way, or is the first time I see you smile? I mean, I didn't mean it as a joke.
I'm going through a really horrible divorce.
What's that?
I'm going through a bad divorce.
Are you going through a bad divorce?
Yeah, so that's been on my mind a lot.
I see.
Haven't seen my children. But no, I'm in good spirits compared to where I was a few months ago.
Are you getting some help?
I am. Yeah, I have. I see a therapist about once every 7 to 10 days in Surprise, and I have psychiatrists that I see, and then I also have therapy with the IOP.
His probation is 2 years.
Right now it's 2 years.
How long? When did it go into effect?
May 23rd, 2019.
We don't have a. This is not a new complaint for a violation of board order, is it?
No.
The DO 190005 is the previous complaint in order. DO 190145 is the complaint for non-compliance with the board order.
Okay. Yeah, because my thought is, Doctor, that clearly there's a violation of the board order. And I'd like to use that to extend the probation.
I'd agree.
More than 2 years. We need to be sure that 2 years is a relatively short time, and we want to, for you, make sure that you're on the right path and you get back to full-time practice and live your life. And probation can always be terminated early, but at least it gives you and us the flexibility to to be able to work with you on it. So
I was thinking extending it to 5 years.
Yeah, that was my thought.
You can always petition and end it earlier.
Yeah. So 145A is the new complaint. Is there anything else, Doctor, you'd like to tell us? You need to tell us?
I think 5 years is relatively common for other physicians that I've met in the program. So I think 2 years is probably a starting point, but 5 years seems to be average for other physicians. So it's not unexpected that it would be extended to 5 years. And I'm okay with that because I'm at this point committed to lifelong sobriety.
Okay for you.
Good. Yeah.
So, I wish I would have known about this self-help program when I started using marijuana in 2018 to cope with my marriage issues, but where I'm at now, I'm a completely different person mentally. I've accepted my faults. I've accepted my self-centeredness. Working the 12-step program has really been a true therapy for me. And like I said, I'm committed to sobriety for myself, for my family, for my parents, for my friends.
Glad to hear that. Do you want to make a motion?
Yeah, I can make a motion to find that the doctor violated the board's order of May 23rd, 2019 by consuming alcohol.
Make a second.
Second.
All in favor signify by saying aye.
Aye.
All opposed, same sign. Now we need to...
I can make a motion that the doctor be placed on probation for 5 years. The terms would be the same terms, I would think, as in 190005. Does that make sense, Justin?
Yes.
And I can go through them, or I can refer to incorporate by reference the order of probation that was issued on May 23rd, 2019 in cause number DO 19-0005. The only difference being probation term would be 5 years instead of 2.
This would be a consent agreement at this point. We're offering him a consent.
If that's the best way to do it.
That'd be fine.
That'd be fine.
And I'll second it. Okay. Any discussion? All in favor signify by saying aye.
Aye.
All opposed, same sign.
And we do need a roll call because
Okay,
it is...
discipline. Roll call.
Dr. Reese.
Yes.
Dr. Madem.
Yes.
Dr. Erbstrasser.
Yes.
Mr. Landau.
Aye.
Dr. Cunningham.
Yes.
And hopefully eventually you'll be back to terminate the probation early.
Do we want to see him back in a
Yeah.
few months, see how he's doing, like in 6 months?
Yeah. Could be good, yeah.
What's today? How about we see him? Holidays are always stressful. See him in January. Let's
Yeah.
put him on the January meeting, okay? Okay. We'll see you in January, sir.
What are the terms of getting out of probation earlier?
You can talk to the executive director about that later, okay?
Okay.
All right. Right now, you've just been extended for 5 years, okay?
Okay, thank you.
And then we're going to see you in January and just see how you're doing, all right?
Okay.
Wish you the best. Good luck with your personal life, too. I'm sorry to hear all the troubles you're going through.
Thank you.
And we'll go from there. Do you want to, should we restrict any, the only other thing I was going to say, should we restrict any of his work or not?
In the previous order, you restricted his practice down to not to exceed 40 hours a week.
Okay.
If you'd
Yeah,
like to
leave it.
modify that.
Okay, we'll leave it at 40.
Well, let me just state also, the order should say that the probation in this case in, let me go back, in 190145A would run concurrently with that in 190005A. So it's not 5 years on top of 2 years. It all runs at the same time.
Yeah.
Just one will end after 2 years, the other one will continue.
All right.
Okay.
Thank you. Good luck to you,
Thank
sir.
you.
See you in January. All right. Next is B, DO-18-0172A, Brian Joseph Coates, DO. License number 005837. Dr. Coates, please have a seat there.
Morning.
You want to talk about this one, Dr. Pra?
Yes, I'm having some computer issues, so I apologize. I thought it was working, but it's really not. Yeah, that'd be awesome.
What else is new?
Do we need to be in executive order for this one?
Yeah, we might
Yeah,
have
it's
to.
one that let's see. Hang on, I'm sorry. My computer is
Take your time.
My computer is doing some crazy stuff. Okay.
This one we may need to go in executive
Yeah.
session.
Yeah, right off the bat.
Okay, so I'm going to make a motion to go into executive session to talk about medical information from the doctor. Can I have a second?
Second.
All in favor signify by saying aye.
Aye.
So if you all can just step outside the door, please, and we'll let you back. open session after talking to the doctor for medical information. I'm going to make a motion that we modify the probation from 5 to 2 years. Can I have a second? Second.
And
Mr. Landau?
just for discussion, and the trauma course? Did you
Sorry?
the trauma course, did you still want him to complete that?
The one intensive outpatient week intensive course.
No,
I think we can delete that.
That time is
Yeah, he went and did a fellowship,
Yeah.
right?
Yeah. So we'll delete that, okay?
Okay.
All right, and I'll amend my motion if he'll amend his second.
I will.
Okay. Do we need to have a roll call vote? Or
Yes.
since it's this one, can I have a roll call, please?
Yes, Dr. Reese.
Yes.
Dr. Madam.
Aye.
Dr. Erbstrasser.
Yes.
Mr. Landau.
Aye.
Dr. Cunningham.
Yes. All right. Good luck to you, sir.
Thanks.
Have a good
Appreciate it.
afternoon. Keep up the good work, okay? All right. Oh,
Nice to see you again.
man. I got logged out again. Hang on just a second. Guys. I don't know what it is. Maybe I just have the...
Got to just keep wiggling that mouse.
Yeah, I guess. Hang on, best be patient with me. Okay. It's thinking. All right. Next is C, DO-18-0155A, Joseph Christopher Thompson, DO, license number 007732. Dr. Thompson, please have a seat there. All right. Do we need to go into executive session right away for this?
Yes, I'm sorry.
All right. Sorry about this, you guys. All right, we're going to back into executive session
Apologize.
for
Medical advice.
medical advice. And I'll make that motion. Can I have a second? All in favor, signify by saying aye.
Aye.
back in open session, we asked Dr. Thompson to come back in January.
Yeah.
Okay.
So I can assure that.
All right.
John?
Next is 8. This is, we're going to applications. So the first one is A, DO-19-0144A, Lori Ann Claypool. Dr. Claypool, please have a seat right there. Welcome. All right. Is this John's or yours?
I'll
okay.
do it.
Okay.
You ready?
Yes, I'm ready.
Okay. So the reason that Dr. Claypool is here is she applied for Arizona license in January of 2019, and she answered yes to professional conduct history portion on the application. The yes answer was regarding several malpractice settlements made on her behalf. She graduated from Kirksville in 1990. She completed an internship there in 91. She began an OB-GYN residency at Riverside Osteopathic in Trenton, Michigan in July of 1990 and transferred to an OB-GYN residency at Kirksville Osteopathic in July of 1993. She completed the residency in 94. She is board certified in OB-GYN. She has licenses in Illinois, Iowa, Michigan, and Missouri. She did state no to question 2 on page 4 inadvertently in her application. She states she was disciplined by the state of Michigan for not having enough CME hours in a 3-year period. She was disciplined in Michigan in 2016-17 for failure to meet the CME requirements for licensure renewal. She was reprimanded, placed on probation, and had a fine imposed. She complied with the order and was released from probation in February of 2017. She was then disciplined in Illinois in 2017 as a result of the Michigan's board's finding that she failed to complete 150 hours of board-approved CME required for licensure renewal and failed to submit evidence upon demand demonstrating compliance with CME requirements for license renewal. She was reprimanded, fined $1,000, placed on probation, and required to complete 3.5 hours of CME. She also had several malpractice cases. One occurred in 1999. The settlement occurred in 2004, and it was for $21,000. A patient underwent a laparoscopy for pelvic pain, adnexal mass, and tubal ligation. Release of adhesions was performed, and the patient suffered a bowel perforation, which was discovered several days later when the patient experienced a fever. The bowel perforation was repaired by a general surgeon. There were no known long-term sequelae. The second case settled in 2005 for an unknown settlement. This case occurred in 2003 when a 45-year-old female was taken to surgery by one of her partners for a hysterectomy. Dr. Claypool was on call, and the patient was admitted for a wound infection. ID was consulted, and the patient was started on Vanco and Gent, and she had a vestibular problem related to the antibiotic. The third case settled in 2016 for $45,000. This case occurred in 2010 when a 50-year-old female underwent a laparoscopic oophorectomy secondary to a large ovarian mass. Postoperatively, the patient developed sepsis. The patient was found to have ruptured diverticula and required a colostomy. According to the malpractice case, the surgery was performed on February 22, 2010, and the patient presented to Dr. Claypool's office on February 25, 2010, with increasing abdominal pain and fever. Lab and x-rays were performed. The white count was 21,000 with a left shift. The x-ray of the abdomen showed free intraperitoneal air. The results were called to Dr. Claypool on February 25, 2010 at 2:37. She ordered antibiotics for the patient and told her to take Miralax. The patient presented to the ER on February 28, which was 3 days later, with an increase in abdominal pain. The ER physician found a distended abdomen and decreased bowel sounds. A CT scan showed diffuse peritonitis and a possible abscess. The patient was taken to surgery and found to have a perforation of the sigmoid colon. She developed sepsis and a severe wound infection. She required a prolonged hospitalization and ventilator support. Did I say how much that settlement was for? Let's see.
No.
Yeah, well, it was only for $45,000, which I'm kind of surprised.
Okay.
Fourth case was settled in 2018 for $250,000. The incident occurred in 2012 when a 29-year-old female was taken for a total abdominal hysterectomy, bilateral salpingo oophorectomy, and adhesiolysis. The patient developed a vesiculovaginal fistula, which required further surgery to repair. A fifth case settled for $450,000. This case occurred in 2015 when patient JR was taken for a laparoscopic-assisted vaginal hysterectomy, bilateral salpingo oophorectomy, and an anterior repair and cystoscopy. The patient sustained an injury to the bladder, which was not recognized at the time of cystoscopy. This also resulted in a vesiculovaginal fistula, which required multiple surgeries to correct. A sixth case is pending settlement. This case occurred in 2013 when a morbidly obese patient was admitted for induction of labor on October 6, 2013. Labor was complicated by an arrest of dilation, and the patient was taken for a C-section on October 7th. She was discharged on October 10th. According to the malpractice case, the patient developed chills, fever, abdominal pain, and drainage from her incisions on October 12th. She presented to the ER on October 15th and was diagnosed and treated for a UTI. The patient returned to the hospital on October 18th with sepsis and was admitted to the ICU. She died on October 19th, 2013. The malpractice case alleges failure to recognize the patient was at high risk due to obesity and smoking, failure to administer prophylactic antibiotics prior to the C-section, failure to perform a timeout procedure, failure to have the patient evaluated on October 14th or 16th, and failure to refer the patient to the ER when she reported symptoms consistent with a postoperative infection. A seventh case was settled in 2005 for $45,000. The incident occurred in 2000 when a patient underwent
450.
What did I say?
45.
45, yeah. Occurred in 2000 when a patient underwent a vaginal hysterectomy in July of 2000. She began to experience bowel leakage from the vagina 10 days post-op. She was admitted and then transferred to a higher level of care. She was found to have a bowel defect. The malpractice case alleged Dr. Claypool failed to order diagnostic testing or consult a general surgeon.
Dr. Claypool, you have quite an extensive record there.
Yes, I do.
Okay. What type of work are you wanting to do here in Arizona?
I'm hoping to be an OB hospitalist. That's my love, is OB.
So you're going to be doing surgery?
C-sections. Can I say, in Illinois, I was never fined or put on probation for my license. That was only Michigan.
Okay.
Nothing happened in Illinois, and again, that was for the 3 CME hours.
Go ahead, Therese.
My feeling is with this preponderance of malpractices, I would want to know what her proficiency is.
I agree. Or we could restrict her license.
Either way, but I wouldn't want to grant a full...
I wouldn't either. How do other board members feel?
I agree with Dr. Reese. I would love to see some information on proficiency before considering a license.
Does PACE have an evaluation, I would think, for an evaluation or not?
They can set up any specialty. It just takes a while.
Yeah.
Sir, is there anything I can say? Because I don't believe what she read is a true reflection.
Well, you could go ahead and say what you like.
Yeah.
Go ahead.
On the one that was the $45,000 for the bowel injury that you were surprised about, the surgeon who did her surgery happened to have Alzheimer's when this went before the court. He was in great defense of it, said that her bowel injury had in no way anything to do with her vaginal hysterectomy, that it was a separate issue. Because he had Alzheimer's, he could not testify. Therefore, it settled for $45,000. The other one you mentioned, I was not on her case. I truly was just a consulting physician for antibiotics. On the one that settled for $250,000, there were 2 board-certified OB-GYNs, myself and another on the case. When she left the hospital, she was fine. She was actually a hospital employee who was up cleaning beds at the hospital, not because we wanted her to, but her choice. She actually had to undergo several psychiatric evaluations for this. In the end, because of her age, my attorney said that we should settle for this. The C-section, which, I can't say enough about a patient who's passed. I mean, that really hits home. That patient was asked to go to the ER. We have that very well documented in her records. She did have follow-up appointments with us that she did not go to. The ER that she did end up going to that treated her for UTI was not our ER. I did not even know she was there. It was an outlying ER. At the time she was seen, she was already in septic shock, and they sent her home on outpatient antibiotics. When she showed up at our hospital, myself, a general surgeon, a nephrologist, pulmonologist, an intensivist, an infectious disease doctor took care of her for just over 24 hours, and unfortunately there was no saving her life. She did have preoperative antibiotics. A timeout was performed, and all of that is documented. We are being, not just myself, but the hospital is being sued by this group of ER physicians who paid out over $1 million, and they're trying to recoup some of that. They settled with the family. The family never sued us, and we are not being sued by the family currently. It is strictly by the ER physicians.
Well, the problem that we have when we review these is we never get the full set of medical records. We only get what is either in the malpractice case or reported to National Practitioner Data Bank, or what you tell us. And so the question I had for you is that in the malpractice case, they alleged that you failed to evaluate the patient on October 14th or 16th. So I'm assuming that she contacted you to tell you that she was not doing well.
She had follow-up appointments scheduled with us for post-op that she failed to keep. We called her and had made another appointment on the 16th, and she failed to keep that one also.
We're not here to retry those cases.
Theoretically, we can pull the 7 cases and start from scratch on all of them, but I'm not sure that's our role. As I said in the previous case, you talk about coincidences. Here we have 7 malpractice claims in 2 disciplines for whatever reason. And I think of where we're coming from. I cannot sit here and vote to grant you a license. So I can just vote no and see what my fellow board members do. Whatever the vote is, the vote is. Dr. Reese has a thoughtful idea, and so we can try to move to the next step, and so do some evaluation of proficiency, considering the 7 malpractice claims might, I think, very well be in order. We still need an explanation as to the other 2 non-malpractice actions. Maybe we could talk about that, but that's my thought. I agree with Dr. Reese, Dr. Madam.
I have done some self-corrective actions. In light of this, I don't do major surgeries. C-sections I don't have a problem with, but I don't want to do major gyn surgeries by myself. If I have a major gyn case, I always schedule it under my partner and I first assist. I have no desire to do major gyn cases at all ever again. And at the time, I probably should have quit sooner because I don't enjoy major gyn cases, and unfortunately, humbling experiences make you realize that.
What about the failure to complete CME?
At the time, I was also licensed in the state of Missouri, Iowa, and Illinois, and I had enough CME for all 3 states and for the American Osteopathic Association. I was lacking 3 for the state of Michigan, and I had made the false assumption that if I was okay in the other 3 states and with the AOA, I was also okay with the state of Michigan, and I wasn't. So I paid my fine and did the CME that I was required to do.
And what about Illinois?
There was no fine in Illinois.
I'm not talking about a fine. It says in 2017, well, it says a fine, but as a result of the Michigan's finding, you failed to complete 150 hours.
I was not put on probation. Nothing happened to my license in Illinois.
Well, Dr. Pratt says that she was reprimanded, fined $1,000 and placed on probation.
That's what I saw on the
National Data Reporting Bank.
So that's another. If that's not the case, you need to get with the reporting data bank and
do that.
show that provide the evidence, to get Illinois to provide the evidence that that's not accurate.
Okay, I can do that.
I think that you can see that this board has a lot of concerns, and we're here to protect the public, okay? So I get it, you want to come to Arizona, but I think that this board feels very uncomfortable with having you practice in this state, okay? So I think there's either you could go for an evaluation with PACE, we can deny your application, which would go on the National Data Reporting Bank, or you can resend it yourself. We'll give you that on your own, so it doesn't go on there. So I think those are the three things that we have as a choice, unless other board members have any other ideas.
Can I ask what PACE is?
It's where they put together a program to see what your proficiency is. PACE is in San Diego. It's what we use to evaluate positions that we feel that may have deficiencies. Okay? It's at your cost, and they put you through the program, and then they give us a evaluation afterwards. Okay? So
For someone like you, it'd probably be about a week long.
So
we use it quite frequently.
So I don't know. Can we give her the chance that she can think about that on her own, or how do we do that, Jean?
You could form a motion offering her a consent agreement, at this time an interim consent, to have a PACE evaluation.
Okay.
If she chooses not to sign that consent agreement within X number of days, then she'd have the opportunity to withdraw the application. If she doesn't withdraw, then it would be denied.
Okay. So that's what I think we should do then. And then, so I'm going to make a motion, as our Attorney General had just stated, that we send you for a PACE evaluation, okay? And then, as she stated too, that you can have the option of withdrawing your application, and if you don't do any of those, then we can also then deny it then as well, okay? And then, should we say that she should have a certain amount of time to sign up for the PACE evaluation?
I'd say by November 1st.
By November 1st, she has to just at least make the appointment. Doesn't mean you have to have it completed, okay? But make the appointment by November 1st, and then complete it in 6 months? 90 days?
Yeah, how long is it?
Well, the holidays are by the
November,
first of the year?
December, January.
January?
By February 1st. Because you got the holidays in there, too.
By February 1st. That's my motion.
I think it'd be sooner.
Second. I have a second from Dr. Madam. We need a roll call then?
Yes.
And just to clarify, the motion would be offer her an interim consent agreement to undergo a PACE evaluation. The appointment would have to be made by November 1st. The evaluation itself would be completed by February 1st of 2020. This deals with her specialty as OBGYN, maybe particular attention to the surgical
OBGYN and C-sections?
Yeah, surgical skills.
Surgical skills.
If that...
And complications. Skills and complications.
If the consent agreement is not signed within typically 2 weeks, she has the option to withdraw within 7 days, and if not, then her application is...
Right, we'll go on the National Data Reporting. Okay.
Okay, so either you want to go to PACE or you want to withdraw your application because you don't want it denied.
Right.
Okay. Right. All right. Okay. Can I have a roll call, please?
Yes. Dr. Reese?
Yes.
Dr. Madam?
Aye.
Dr. Erbstosser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. All right. Thank you.
Thank you.
All right.
And then if you go to PACE, once we get the results back, we'll reschedule another hearing.
Another hearing.
So you'll come back.
Right.
We can review it all.
All right, you bet. So B is DO-19-014A, Brian F. Katzer. Tang. I'm sorry if I didn't say it correctly. Apologize. Welcome, Doctor.
Thank you.
All right. John, I believe this is yours.
Yes, sir.
All right.
Byron Sang applied for Arizona osteopathic license on May 9th, 2019. He meets the education and training and examination requirements for licensure. Dr. Sang disclosed a yes answer under the professional conduct history portion of the application regarding any awards or payments made on his behalf to resolve a civil suit or malpractice claim. The details regarding the yes answer, Dr. Sang advised that on March 25th, 2009, a 12-year-old male presented with his mother to the emergency department with the chief complaint of right ankle swelling and difficulty with weight-bearing pain. The history indicated that the patient may have fallen during the evening. His mother indicated a solitary bruise to the right ankle, and he was administered 10 milligrams of ibuprofen. Vital signs were again ordered, and the patient was again evaluated by a senior resident. The examination did not reveal ankle swelling, and the findings were significant for right ankle ecchymosis, tenderness to ecchymosis.
Ecchymosis. You're doing fine.
And right calf tenderness. There was no sign of rash, no alteration in mental status, and a neurological examination was unremarkable. The patient's right ankle and hip were x-rayed and found to be negative. The patient was placed in a posterior splint, and repeat vital signs were ordered, but they were not performed before discharge, and he was discharged home with a recommendation for follow-up as needed. Approximately 7 hours later, the family noted the progression of a rash on the patient's lower extremities, and he had a fever. The patient presented to a different emergency department and was diagnosed with I can't pronounce that, but
meningococcemia.
Okay.
Don't worry about not being able to pronounce that.
He was admitted and treated with IV antibiotics and was discharged home after spending a week in the hospital. A lawsuit was filed on February 15, 2010, and was settled on September 19th of 2012. The settlement award was $1,750,000, with $750,000 assigned to Dr. Sang. Dr. Sang reported that there was no investigation or review by the hospital or Pennsylvania State Board.
Doctor, tell us about that, this case.
So I saw this child, young man, in an emergency room with my senior resident, as it said in there. He came.
What year? I'm sorry. What year were you when this happened? What year in your residency were you?
I wasn't attending.
So what? Oh, you were attending. Okay.
Yes. I was at a teaching hospital.
Okay.
Saw the child. He came with a normal mental status with his complaints described as per the report. We evaluated him, both of us, and it seemed at the time that he may have had a musculoskeletal injury. Obviously, it did not turn out to be the case, and it's been following me for a while to deal with. But we discharged him home, and he obviously had progression of disease. Was brought to a neighboring pediatric emergency department where he was diagnosed and treated.
What was there complications with getting it? Did he develop encephalitis, seizures?
So as far as his,
it's a pretty large award.
It was. So the foot issue that we had initially seen around his ankle, the ecchymosis, became necrotic from the reports that I received from the facility. He had to have some plastic surgery, calcaneal debridement, and then extensive physical therapy afterwards. But that's by report, too.
Okay. So, to make those kind of diagnoses, you got to really think hard. You saw it in a very early stage. This is my opinion. And it's really hard to say, well, that's what this is. Well, then he presents to a different ER after a time lapse. Then the picture becomes bigger, and you can see it. Now you're thinking about it. So I just feel sorry for him.
Dr. Maiden, you're the ER doctor here.
Well, can I ask you, the vital signs were again ordered. Why were the vital signs ordered again?
So I ordered the vital signs because he was tachycardic at the nurse's triage. When I saw him with the senior resident and myself on physical exam, his vital signs were closer to normal, and his mental status was also clear. I did not document my repeat vital signs in the chart. That was my mistake. I also did not push for the nursing staff where the order was placed almost immediately upon his triage to repeat his vital signs either, which was also ultimately my mistake as well. nor did my resident document the vital signs on his exam, which was also my mistake. So
It's kind of the classic disaster when your partner tells you, remember that patient you sent home with abnormal vital signs?
And honestly, that night I was still on shift doing charting, and the family had already come back asking for the chart. So this was, a rapid progression with a rapid response.
Did it look like a bruise when you saw it? Did it look
I believe
like a bruise?
it did look like a bruise. It was on his lateral malleolus. In hindsight, it's more. I should have done more.
Anything you're doing differently now since that all happened?
I am extraordinarily vigilant about vital signs and how they correlate with clinical pictures.
For a lay member, this is actually rather typical to have meningococcemia progress that fast, and it can easily look like a bruise or achy joint or just a limp, and then a half a day later it'd be a medical disaster.
Oh boy.
And that's just the nightmare we all face when we see these patients. So outside of making sure the vitals get signed, I honestly, this is a horrible case, but I do not have a problem with recommending a license to this patient.
Where are you going to work?
I work for Teladoc Health.
Okay.
I'm an associate medical director with them.
Oh, so you just have to have a license. Correct.
And I'll be doing, yes.
Is it administrative?
It is patient care as well.
Okay. All right. You have a motion from Dr. Madem. Do I have a second?
Second.
Second from Dr. Erswasser. Any discussion? All in favor signify by saying aye. Giving
Aye.
Unrestricted license. Welcome to the state of Arizona, doctor. Good luck to you.
Thank you all.
All right.
Dr. Madem, for our own edification, is this, would the pathognomonic thing of this would be that there would be a swollen joint in a child or a painful joint with no injury?
So the problem with this case is the mother said they thought there was a fall or injury, and it looks like a bruise. And the x-rays are always going to be negative, or almost always going to be negative in that case anyway, so the evaluation is perfectly appropriate, and that's just, if they come in saying there's no injury, my child can't bleed there, we have a much higher index of suspicion.
Is it a certain age or no?
There's a large variability to it.
Okay.
It's rare, isn't it?
It's very rare.
Yeah.
And what
But you can go get it.
It's
Meningococcemia.
it's a bacterial infection.
Bacterial infection.
So what are the long-term effects?
Well, sepsis and death is unfortunately
Yeah.
It's normally death.
But this child?
No, he's fine.
He didn't die.
All right. Thank you. Just discussing your case.
We all try to learn every day.
All right. Next case is DO-190086A, Timothy Francis Timmons. Dr. Timmons.
I didn't know it could present as a bruise.
Welcome, Dr. Timmons. Thanks for being so patient. I've seen you here for a long time. All right.
I used to work in West Hempstead.
Oh, you did?
I worked at a department store, which is no longer there. S. Klein on the Square.
S. Klein on the Square.
I was a store announcer. And S. Klein on the
It's not
Square.
about you guys.
Yeah, I was in college.
I went to S. Klein.
I would say, Dr. Schattenberg, could you read this?
That was the main one.
14th Street.
Yeah, that was the main one.
Thank you for the promotion, by the way.
Okay. Yeah.
Okay.
Is it a promotion?
You're going to have to learn how to pronounce it.
Yeah.
All right. Okay. Timothy Timmons applied for an Arizona osteopathic license on January 2nd, 2019. He meets the education, training, and examination requirements for licensure. Dr. Timmons disclosed a yes answer under the professional conduct history portion of the application regarding any award, settlement, or payment made on his behalf to resolve a civil suit or a malpractice claim. The details of that are that he reported the reason for the yes answer was a case where he was not a patient's primary care doctor, but he participated in the patient's care as the covering physician for the urgent care clinic, Doctor's Immediate Family Practice, in West Hampstead, New York. Dr. Timmons' involvement in the lawsuit concerns a period of 6 office visits provided between February of 2007 and January of 2008. During those visits, he addressed the patient's concerns of hypertension, hypercholesterolemia, chronic pain with secondary chemical dependence. As a part of this patient's care, Dr. Timmons referred him to cardiology, neurology, and pain management and recommended GI consultation after he informed Dr. Timmons of his past medical history of hepatitis C infection. The patient declined the referral, stating that he was already under the care of gastroenterology. In 2008, Dr. Timmons was named as a defendant in a group medical malpractice lawsuit filed in the Supreme Court, Nassau County, New York, by the widow of the now-deceased patient. An allegation of medical negligence was based on the claim that there was a failure to properly monitor and treat the patient's hepatitis C and failure to diagnose his liver cancer. Dr. Timmons said his responsibility in the case was that he did not properly document in detail his recommendation that the patient was to follow up with his gastroenterologist regarding his hepatitis C. Excuse me. In addition, Dr. Timmons did not document that the patient claimed he had been under the care of his gastroenterologist. Dr. Timmons' malpractice carrier advised him to settle the case out of court. In March 2012, Dr. Timmons consented to allow his insurance carrier to settle the case for him out of court. In August 2012, the case was settled in the total amount of $525,000, of which his insurance company paid $250,000 on Dr. Timmons' behalf for failure to monitor and treat the patient's hepatitis C, which resulted in the patient's death from an inoperable stage 4
hepatocarcinoma.
Okay.
Good job, John.
Good job. You know, this is an unusual case. So what happened with this, with Hep C?
It is. I mean, any specific starting point you'd like me to check out?
Was this an intravenous drug use, or what was the, how did he get Hep C?
Yeah, it was a history of IV drug abuse.
Okay.
A distant history of that.
I know that, we have treatment now that's much easier. Back then, we had
that was part of the issue.
And a lot of patients don't want to do that, but I'm not sure how it got this far along. If you had a GI specialist, how did you get involved with that?
Okay. So the documentation of hepatitis C in the chart that I had, which was a paper chart, was made by me because at the end of a visit for another matter, he had mentioned that he had a history of Hep C. We had two good GI docs in that area, one that I tended to work more with, that were just kind of updating us on the pegylated interferon kind of advances at the time and better tolerance. And so the patients that I came across with Hep C, we would just direct to them for evaluate genotypes. We might run a test for genotypes, but we pretty much turned it over to them for workup and recommendations, including monitoring for hepatocellular carcinoma. When he mentioned it to me, that there was no mention in the chart that I had available that he had the Hep C, so I felt, well, we had a conversation about this, could I refer him to GI, and he declined. He says, no, I've already got a GI doc, and I tried that interferon stuff, and it made him very ill, and he wasn't interested, and I tried to let him know that there was a newer generation of medical options, that he should have a conversation around that. He goes, yeah, okay, fine, but I don't need the referral. Unfortunately, he was alone with me at the time, as with all his visits. So my response was to just put on his problem list, which was a face sheet on the front of the chart, that he had Hep C, so that I could remember that in subsequent follow-ups, and that anybody who saw him would be aware of that as part of his medical history. I'm not sure. I don't want to digress too much. So how else? Yeah.
So it sounds like you had documented the Hep C, but you just assumed the GI doc was doing the Hep C viral loads and doing the ultrasounds. And
right. The monitoring.
Yeah, but because there was poor documentation, then clearly he hadn't been doing it, I guess, and so they fell back on you. Is that where we're at?
So what happened is that once he became ill about a year or so after I had left New York to go to Washington, the Seattle area, but in 2008. And this came to my attention, I think, in 2009. About a year or so after I saw him, he became ill, and eventually went to see a GI doctor, and was found to be had inoperable hepatocellular carcinoma. As part of that discovery, and when his medical records was forwarded to me in Seattle, I was able to have access to a prior chart, which I wasn't aware about at the time that I saw him, where the owner of the clinic, a family practice physician, had diagnosed it a few years prior to my meeting him, but according to the patient, he had known about his Hep C even long before that. He said he had it for at least a decade. But the diagnosis was made by lab work a few years prior to me seeing him, and he was referred to the same GI doc. There was documentation around that, to the doc that he eventually went to when he had full-blown hepatocellular carcinoma. So I don't believe that was the same doc that he had been talking with before, that he told me that he was involved with. But when I was able to go, when I flew back for the, I guess the discovery or disposition, I'm sure, deposition, I was just informed, and I was just informed on the day of the disposition that I was just to answer yes and no. That was the format of the disposition, and that no one brought up the fact that, and so the kind of the implication was you should have referred the guy to GI, and documented that, even though that had already been done. Dr. Wong was apparently one of the reasons why it took so long is the deceased, the spouse of the deceased is the one who brought the lawsuit, and it originally leveled it against his primary care doc, the owner of the clinic I was at. And as it turned out, again, I'm not sure about the legal dynamics here, but it turned out that he'd been sued before, and in response to that, I think multiple malpractice suits, he decided not to carry malpractice insurance.
So they went after you.
So they went after everybody who saw him. And so then they brought us into it, and of everybody who saw him, I saw him 6 times, so I guess that mattered.
Okay. Any questions, Dr. Erbstrasser?
No, I don't.
I don't have any. I just wanted just curious what was going on. I'm sure you refer everybody now we have cure.
Right, yeah. One thing that has stuck with me, I mean, just since I heard this conversation earlier today with other physicians, is that having left that, I was working at a community health center in Seattle for the last 10 years, and I was medical director of it, and we had a lot of homeless patients, percentage-wise, and several of them, baby boomers, the age group you would expect. So it did make me more proactive in trying to get them to come back for the follow-ups, to get the sonogram studies done, the alpha-fetal protein studies, to hook up with GI clinics. So it made me more of a go-getter in that regard.
Where are you going to be working here?
I haven't decided. The reason I'm in Texas now, in San Antonio, and the reason for that is I have 3 sons, and my youngest son decided he wanted to, having just finished business school at the University of Washington, wanted to go to dental school, and had pitched me a whole good strategy about maybe doing dental school in Texas. And so, and my wife, having arthritis, she's also a pediatric psychiatrist, was just kind of fed up with the weather up there. Anyway, we moved down there on the auspices that he would go to dental school. He has since decided to pursue software engineering vis-a-vis his fiancée, whose family lives in Seattle, and they're trying to rope him in. So I have a son who's going to law school in Tucson. And of my 3 sons, he's the only one who's not married, and he'd like us to be close. We like Texas, but we'd rather be close to our kids.
I was born in San Antonio, so yeah. All right. Can I have a motion? I'm sorry?
Is that what happened?
Is that what happened? Exactly. That's what happened. Fort Sam Houston Burke Army Hospital. Anyway, can I have a motion for
I make a motion for
unrestricted license? I'll second that. All in favor, signify by saying aye.
Aye.
All opposed? Congratulations, sir.
Abstention.
Huh?
Dr. Maiden wants
Dr.
to
Maiden
vote.
no abstention. Okay.
And actually, I want to give you a thanks in part because this is, I don't know if catharsis is the right word, but it's the first time I've had a public airing of actually what happened. It was one of those things where I just had to go through it.
I'm sorry to make you go through that.
No, but thank you for your consideration.
You bet. Yeah. Welcome, sir.
Hit the restroom.
All right. We're going to give us 5 minutes here. We'll be right back, sir. Is this yours, Dr. Pra?
No, it's not.
Is this
It
John's?
belongs to John.
Oh, John, this is
Dr.
yours.
John.
Thank you. Or is this
You're not
yours,
going to forget about that, are you?
Justin, I don't remember.
I will have something to add.
Okay, thank you.
You want me to read this one?
Yeah.
Okay.
Yeah, if we would like to call the case. For
Oh,
the
I'm
record.
sorry. This is case DO-19-0064A, J. Sue. Dr. Sue. Welcome, Dr. Sue.
Thanks. Okay. Jesu applied for Arizona osteopathic license on December 1st, 2018. He meets the education, training, and examination requirements for licensure. Dr. Sue disclosed a yes answer under the professional conduct history portion of the application regarding being placed on probation or having his privileges restricted or suspended, terminated, or any other adverse action against his participation. The details are that Dr. Sue reported that the reasons for the yes answers, his residency training in internal medicine started in July of 2016, but he was placed on academic remediation in June of 2017, which extended his contract by 3 months. He was placed on academic remediation again in September of 2017, which extended his contract by another 3 months. In March 2018, he was again placed on remediation until the end of his PGY2 in December of 2018. The reasons that were cited for his disciplinary actions were untimely attendance, unexcused absences, and incomplete progress notes. He believes he has demonstrated improvement in that regard. Dr. Sue advised that there were no concerns raised since March of 2018. Dr. Sue also advised there was an incident that occurred in October of 2018 where he placed a central line without supervision, which led to an adverse event. The catheter was inadvertently placed in the carotid artery, and the patient had a hemiplegic stroke. Dr. Sue reported that in November of 2018, his program gave him notice that they did not intend to renew his contract in his final PGY 3-year of training for 2018-2019. He believes that the incident with the central line and the aforementioned concerns considerably led to this decision. Dr. Sue acknowledged responsibility for the incident and said he explained the exceptional and emergent nature of the situation, which he believes warranted his action during that time. He appealed his decision to the Clinical Competency Committee and to the Graduate Medical Education Division Chair, but the appeal was not successful. He attached a copy of his appeal letter to his explanation of the yes answer. Dr. Sue said he has reflected on these events and endeavors to finish his residency. He is in the process of applying to other residency programs to become board certified, and at this time he is seeking to obtain his medical licensure, in which would allow him to find work and strengthen his experience in practicing medicine.
He has a license, though, in Texas now. It's restricted, correct?
That is correct.
Is that you're going to tell me?
That's what I was going to add, is that the board reviewed this application in June. Dr. Sue notified the board that he had applied for a license in Texas. He'd been granted a license under probation for 2 years. He was required to be working under a supervised physician that had to be approved by the executive director. The staff has obtained that license verification. It's there available for your review. Dr. Sue has requested the license from the Arizona board. He agrees that he would take licensure under a similar probation here, and I can have him speak for it, but he would like to have an Arizona license in practice here.
Dr. Sue, is there anything new that you have to offer us that we haven't heard already from you?
So the situation was that I was working at a family medicine clinic since leaving residency in Texas. The plan was hopefully to practice there at that clinic after having just received my Texas license to practice medicine, actually. But the funny story is that doctor that I've been working with was diagnosed with a terminal illness. He sold his clinic, and I'm no longer working with that clinic because he sold it to a large company. That large company doesn't wish to keep me there because I'm not board eligible. So you can imagine my situation of having to find work to support myself financially. I reside in Texas currently because that's the site of my training, but I'm hoping to find something here in Arizona where I live with my parents.
Do you have anything lined up? Have you gone anywhere?
So far I've been looking ahead, but as you can probably imagine, the job opportunities for non-board eligible physicians are quite limited. The only thing that I've seen that consistently pops up are things like doing screening physicals for Medicare. I think that's what it is, but that's something I could possibly imagine myself doing, at least for the time being, to cover myself financially for student loans and such. But with a restricted license, similar to the one I received in Texas, stating that I can only practice in an institutional setting or a setting with other physicians, that could, doing this kind of a job could be quite of a challenge. It would be a barrier, in fact.
How do other board members feel?
Still uncomfortable.
I'm going to tell you, I still feel uncomfortable with myself moving forward with that, and I appreciate the difficult situation that you're in, but I think also, again, I remind everybody that we're here to protect the public. The other thing is that with his history, and I'm going to go with Mr. Landau, so many coincidences even in your training program, and also then the last issue you had with the poor outcome with the patient with the central line. It makes me feel uncomfortable granting him a license. I'm just going to tell you that.
Yeah, you know, the line, the issue with the line could be poor judgment or over-enthusiastic. That in itself I'd have to think about. But the problems in the residency, and not just one problem, the residency program, academic remediation in 2017, again in June, then in September, and then in March of 18.
It's all 3 years, is that right?
Yeah, and then...
I just want to make a correction.
If I can finish. And, you know, you combine that, and I realized there were no problems, well, at least academically, since March 18. But then we have the incident with the line in October of 18. So it's just a pattern over almost the parts of a 3-year period. And so I have the same concerns.
Go ahead, Dr. Reese.
Let's, for hypothetical purposes, assume that Dr. Sue never took a residency. He just came here and wanted a license to practice after an internship, PGY 1. And would we grant him a license? I don't know. By law, he's entitled to a license. He goes into a residency and he's not proficient, and he does something, whether it's impetuous or poor judgment, we'll never know, and he probably doesn't even know. But in my mind, is he better off having had that couple of years, even though he didn't perform well, than if he came here right after his internship and applied for a license, in which case we probably would have given it to him?
I understand what you're saying, but clearly, though, on the other hand, I'm going to say he wasn't proficient. It showed poor judgment. He didn't pour. So and in any case, so if he would have had, we could debate this all day. Is that he could have had a license, and then could have had a poor outcome after being in practice. But this is a predictor.
Right.
I'm going to say we have a predictor now.
What I'm getting at is he's probably better educated for having this poor residency training than he would have been if he came here and got a license.
He may be better educated, but I don't know if he's proficient.
Yeah, it's the same. To take it a step further, under your scenario, so now he gets a license, And then there are 3 instances of practice that are brought to the board's attention because of some deficiency.
I understand that,
So,
but where, again, it's hypothetical and it's looking into the future. Had he come here to get a license before he started this residency training, we would.
You're gonna make me want to eat a York peppermint patty.
the last person who before us, she got a license before there were 7 malpractice claims. So.
Just trying to find a path for him.
I agree with you, and I want him to finish his training, too. I do want
Yeah.
a path for him, but we can't walk into it with blinders on either.
I'm sorry?
We can't walk into it with blinders on.
Yeah.
How do you feel, Gary?
Well, I think there's 2 ways you can look at it. You can get into a residency program, okay? 2, you can grant him a license, but we have this question about his proficiency. Do we want to send him to PACE? Do you want to get him evaluated and see where his skill level and his intelligence level is at? Or we grant him a license. So I need to see him do residency. I need him to finish his residency. And maybe it's not going to be in family practice. Maybe he's going to physical rehab or something. But he really needs to do a residency.
Can he get into a residency program after what happened in the previous residency program?
He's going to have a hard time getting into a residency.
No, but he may do something different in terms of a residency. It doesn't have to be family practice. It could be rehab. It could be internal medicine.
And I think we also have to have a certain level or standard of care for our physicians, just like we had dealt with this last one as well. And I think that we have adequate information here, and even his residency program, when he appealed it, stood. So I don't think we can ignore all that.
Well, that I would expect.
So
the odds are overturning it when you appeal it to the same body.
Right. So again, I don't know. I'm going to ask Dr. Madam, what do you think then, too? What's your feeling on the process?
I just don't think at this point we could comfortably grant him a license. I would like to see steps made to be able to get there, though, but I don't think I could. I'm just not okay with saying so at the time.
What kind of license do you need for a residency program?
Training license.
PGD. But he's not asking for that. He's asking for a
Full unrestricted.
Yeah.
That includes narcotics, all of that.
What do we do with training license?
PGGY, PGT, postgraduate training certificate.
So it's a license, but still you have to be supervised.
But he's got to have a residency program. You
have to be in a residency before you can get it.
Yeah. Are we entitled to any of the information from his residency program that would give us a window on to actually what happened or what his deficiencies were?
Can we go through all that?
Well, they just send you, like a kind of a Reader's Digest version. They don't give you a lot of detail.
I just he's young and he's put in a lot of effort to get where he is, and I don't want to just close the door on it.
I'm not saying close the door. I just think that it's too early. I think that his path would be is to stay in Texas, find another program or primary care doctor you can find a job with for the next couple of years, get out of the probation of Texas, and then come back and see us after you finish your probation in Texas, and we'll talk to you then. But I don't feel comfortable giving him a license, man.
Yeah. Texas is a pathway.
It's not a shut door. He can make a living.
Yeah, so Texas is a pathway to get out from under everything in the past. And
Have you tried to find a residency?
I'm trying to make efforts every day to find a residency, but the application cycle only occurs once a year.
Yeah.
I'm going to tell you, I would take anything you could get. I'd look at other things with primary care. I'd look at anything that's out there, internal medicine, peds, anything. Take anything that you can get into. Let's tell you that. I wouldn't be picky. I wouldn't choose any areas of the country that or regions or stuff. If you have to go work in Buffalo, New York, go to Buffalo, New York.
My wife was born there.
It's cold and snow, but I mean, I'm just saying, I would do all those things too. But again, you can see the resonance that this board has. Dr. Reese is a very kind man, and so and has a lot of experience with dealing with these things and working with residents in the past. But I don't feel comfortable giving you.
Yeah, I have a very, very strong presumption in cases like this to grant the license.
Because did you grant it?
I'm generally what I'm getting at, because you worked it, you passed COMLEX. Right. But here, there's enough here which tells me, no, not at this time. So.
Well, it's not like he doesn't have a pathway. He does.
Yeah, he does.
Have the ability to go back to Texas and work and be supervised. Maybe do some networking, get to know people, show them your efficiency and how good you are. I mean, it's kind of like you got to start over, but you're going to think about practicing medicine for 25, 30 years, 40. You need your residency.
Have you looked for programs in Texas? Do you have employment in Texas?
I currently don't have employment.
Have you really looked in Texas, or the idea was to move to Arizona?
The idea was to move to Arizona.
Yeah, I suggest if you can go to Texas and prove yourself, that could provide a pathway, number one, to residency, and number
got to
two,
be
to
somewhere, even if it's in a rural area with a dock
Mm-hmm.
somewhere, that you could go work with somebody. I'm telling you, there's got to be an opportunity there for you.
Yeah.
Okay.
Since you do have a license.
So,
yeah.
My feeling is we give him the opportunity to withdraw, so it doesn't show up in the national data reporting
Right.
bank. So, or we deny the license. So, I don't know. How do we handle that?
You could make a motion allowing him to withdraw his application,
Right,
and if it's not withdrawn in 10 business days, then a notice of denial would be issued.
I make the motion just as Gene had said, and if I can have a second. Second. Made him. Any discussion before we vote? Do we need to do a roll call?
Yes.
Roll call, please.
Dr. Reese?
Yes.
Dr. Madem?
Aye.
Dr. Erbstrasser?
Yes.
Mr. Landau?
Aye.
Dr. Cunningham?
Yes. Good luck to you. I really want to see you back in this state, but it's too early, sir. Okay?
Okay.
All right.
And don't look at this as punitive. I mean, I know it is, but
I don't think
really
it's punitive.
look at it as a way to start over.
Right.
Because I'm worried about you. I'm really worried about you.
Okay.
I hope that you find your way.
Thank you.
All right. Good luck to you, sir.
Thank you.
All right. And I'm logged out again. What, is there anything else that we need to talk about? Oh, the calendar.
Yes.
9. Has everybody looked at the dates or had a chance to?
Kinda.
I just haven't had my wife.
Yeah.
I put them in my. It's too early for me to tell. I don't know.
That's fine. I'm just trying to.
Okay.
Oh, thank you very much.
Okay.
No, thank you.
Okay. Want to go to 11? Anything else?
I just want to check one thing on the calendar.
FSMB?
Well,
We already did that. Oh, we already did.
FSMB in part. We'll be back because I was looking at Jewish holidays because we're going to be in South Africa for FSMB in September, but we'll be back by the 18th.
South Africa, cool.
Yeah.
Cape Town.
The April date is my 30th anniversary. Shark. So you won't be there. Right then. As long as I
You
can
mean
be
the next
excused.
one from now? No, it's October.
16th.
The next board meeting is October.
October 19th.
19th.
Yep. So
These are the dates for
the
next
board meeting calendar dates are acceptable for now.
Right now it is.
Okay.
You guys have a great day, good weekend.
All right. Thank you, sir.
Take care.
again.
Thank you. Take care.
Fine.
If they're acceptable, then we'll move on to.
Oh, wait a minute. Wait. Oh,
Sorry.
okay. The Yom Kippur is the evening of the 27th. So 26th is fine. September for now. Okay.
Go ahead, sir.
Do we need to take a motion for that? No? Okay.
No.
Then moving on to 11A, report on executive director dismissed complaints. These 6 complaints were reviewed by the internal medical consultant, or the investigator with recommended for dismissal. So we've sent those dismissal letters, except for case DO180169A. This was a medical malpractice case. It was reviewed by committee members and dismissed by the committee.
Okay.
Then moving on to the executive director's report. As you can see, I've kind of given you 3 months back on the investigations. We are churning through the cases. We're keeping up with getting inputted and to the initial investigative phase. We'll start clearing those out through executive director dismissals as well as case review.
How far behind are we?
I won't say that we're behind. We have about 60 cases that are pending the investigator or medical consultant review.
Okay.
So, the budget we've
You have
had.
a new chair coming in January, and I heard he's a hard ass.
We are about 20% through the fiscal year. We were appropriated $1 million. We've used about 12% of that appropriation. We've only gotten in the first 1% of our revenue. That'll, of course, go up as we get into our renewal season. Licensing, we have no... Oh, I take that back. As of the date of the report, we had no pending applications, but we have 2 that we received and are processing this week. We are down to 36 that are deficient, down from 40 or so.
And those go back to the applicant.
Correct.
Right, saying fix it.
Yep. So we've dropped our number of days per application. We were at 90 prior to the fiscal year change. We were at 60, then 45, now 35 days.
Congratulations. Good job.
It's great.
So you can thank Megan and our new licensing administrator,
Thanks,
Chris.
Megan. Thank you.
Great job.
So, and last thing is the average time frame for issuing the final orders of the board are taking about 3 days.
Oh, that's great.
Fantastic.
And next meeting is October 19th.
Where are we on staffing?
So we are fully staffed and have everything taken care of for going forward.
Good.
Okay.
Good. Please, everybody, come to the board meeting because I'm going to have to recuse myself for the Sapola case. So we're going to need that.
Yes, we're coming back. And that will take a while.
Yeah, we've scheduled that for the afternoon session so that we can get through the majority of the cases.
Can you just make that the main one in the afternoon?
Yeah.
I wouldn't do anything else. We can do the bunch of cases in the morning. Maybe I can leave in the afternoon. What do you think?
No, seriously, you should be able to. We should be able to do everything else, Doug, but you can leave in the afternoon.
I'll hang out. You know I got to hear what happened.
2 hours.
Okay.
For the record, Dr. Cunningham said the meeting would end at 2:15.
I
did. So
He
close.
gets a peppermint patty.
I get another peppermint patty.
We have not officially adjourned yet.
Thank you all for your good work.
But, is there a motion for adjournment?
I make a motion for adjournment. All right.